to carry our own weight. And so the question is no longer whether integration will happen. I have just mentioned it's happening. You like it, you don't like it, it's happening. So the question is how you as an individual want to take part in it, and how we as a collective will design it. So even as we live here with very good communication, I want us to live here with option number 2, which is very individual, a decision, a commitment to one integration action. And that action should be very specific and should allocate responsibilities to all of us. Technology and healthcare are changing, and they are fast-paced in the change, and we must change too. But putting this platform together, which is the integrator, gives us a framework that allows us to absorb the shocks, allows us to absorb the panic, but also allows us to push forward in a more focused, in a way that we can control somewhat the outcomes.
Giving us the recap. Yesterday, our main guest was our PS, and he reminded us just to know who the integrator is. And I believe you and I are the integrators, and we just need to take up the role. I'm going to invite our first presenter of the day, Dr. Tobias Ondeki from UON. Dr. Tobias, he's from Biosensor, and is going to be presenting on what Biosensor does. So karibu sana daktari. Let's have a loud of applause as we welcome daktari.
Good morning. Okay, let me use this one. This is better. My name is Tobias Ondeki. I'm representing a company called SD Biosensor in this occasion. And I've been given a very short time, but I just want to clarify that we have a booth outside for more clarification and more questions. So SD Biosensor is a company that manufactured equipment and the main focus is what is the theme of today, that the integration and looking at doing diagnosis as fast as possible, and this one will actually reduce the load that I saw the PS was talking about. So the focus is mainly on HIV, syphilis, and um, so basically, I'll just introduce the biosensor. So that is actually that is the plant in Korea, and it has actually grown. We are looking at some figures there showing the growth from millions of 142 to 1 billion US dollars, and that is that is actually where so the SD biosensor started in 2009. In 2020, where we had a crisis of what is it called, the coronavirus, it was approved by, pre-qualified by WHO as a test, but it later got, especially in the proper launch happened in 2021, and you can see some of the approvals. We are talking about the Korean, European Union. There are some products that are already pre-qualified there, talking about Canada, US, and Brazil, among others. So that is, all this information are available. So what are we doing? We have two products. One we call Standard Q. It is fast, rapid, and also approved and qualified by WHO and US FDA. The advantages, the low cost, but very high sensitive and very specific. So it is actually effective kit at the point of care. Point of care, I think what everybody wants to get is to get results as fast as possible, so that you apply that information to make informed clinical decision. So there are lists of some of the products that are there, that some of the pathogens and all the disease areas where actually Standard Q can actually give information or do the tests on. So that is one product. Now, these are some of the countries where that Standard Q is already being used. Standard Q used for HIV 1 and 2 tests. So adoption, especially in Africa, we have the Zambia, among others, the Uganda, and even Kenya. We have the products already, just waiting for the launch. So what would it bring to the table, the product? First, it will save the time because a rapid test. You only need to collect one blood sample and cost effective and so on. I think those are the information that, so that's just giving what we are talking about. 20 to 25 minutes. You already have your results, and as you wait, those are some of the procedure we've just given. Like I've just said, you can kindly visit our booth outside for more information due to the pressure in time. The other product that is now being tested at Cambridge, it's already in the product, is what we call Standard M10. So this one, also we talk about accuracy, simplicity, and it gives clinicians easy time to make diagnosis because it's very fast. So those are some, I think what we have it tests the hepatitis, it tests the HIV, it also tests syphilis in one go. And I think what is, and hepatitis B, HIV, and syphilis at one go. What is available in the market, I think only tests 2, but this one has that advantage of testing the 3. So this is actually some of the procedure that can be used. So it does 2 things. It tests the disease itself, drug-resistant TB, and then also checks the resistance of some of the commonly used anti-TBs in the in the healthcare setups. So this is the hospital where this, the tests have been done, they have been evaluated and approved. And we are talking about greater than around 94% sensitivity, and then more than 98% specificity in testing the rifampicin, isoniazid resistant, the drugs themselves, the TB, the multi-drug resistant TB. So it will, we have the product. We are waiting for approval from KEMRI, but the product is already in the market. And I think I want to be as that short due to time constraint. I don't know whether that will be where I would end. But for more questions, for more explanations, for more illustrations, we have our booth. We even have the kits there. We can show you what they can do. Thank you. I don't know whether I've taken more time.
Thank you so much. Thank you so much, Daktari. We look forward to seeing your products even at the booth. You can take your seats. Let's give him a loud Sorry for that. Our next presenter, we are going to be talking about money. We all love money. We are talking about finances. So I'm going to invite Walter Morori, the Regional Corporate Relationship Manager, Government and Public Sector Banking, Cooperative Bank of Kenya. Walter, karibu sana.
Good morning. You can hear me? All right. Hamjambo once again. Bwana Yesu asifiwe. I'm a Christian, allow me to say that. And for my brothers and my brothers and sisters from this other side, Assalamu alaikum. There's none in the room. Mko salama? Good to see you all. Well, as the moderator has said, my name is Walter Morori. I work with Cooperative Bank. It's a pleasure to be here. So today, just going to give you a brief about who we are, and also just as the PS said yesterday, there is no money. Well, I'm here to bring you the good news. We have money. Involve us, engage us. We have our tent right outside. I think you've seen banks publish their results. You see there's money, right? Come, engage us. We have our foundations. We have our CSR investments. So please do involve us. So briefly, what is our purpose as a bank? And before I begin, allow me just bring the greetings of my GMD and CEO, Dr. Gideon Muriki. Amewasalimia sana. So our purpose is basically to transform lives. And our vision is to ensure that we become a dominant bank in the region, to offer a wide range of innovative innovation solutions as the mission. So I know you've heard of Cooperative Bank, but do you know what we stand for? Our values and our presence. We have over 214 branches across Kenya. And where we don't have a presence, you've seen our COPCO Jirani agents. We have about 17,000 of them. We have about 617 ATMs and CDM machines where we serve you. Who owns Cooperative Bank? You are my employer. I know in one way or the other, you belong to a SACCO. So 65% of the cooperative movement, which are the SACCOs, do own the bank, with the remainder, about 35.4, being owned by the minority shareholders. So we do have subsidiaries. The Corp Trust Investment Services, this is an asset management company that allows you to invest with them for the management. We do have Kingdom Bank, which formerly was Jamii Bora Bank, which is owned 90% by Cooperative Bank. We do also own Kingdom Securities, where you can do your shares on the NSC. We do have Cooperative Bank of South Sudan, where we own 51%, and the remainder of 49% is owned by the government of South Sudan. We also have Coop Bank Fleet, where we assist you in fleet management of assets and everything else. You don't have to own it, you can just lease it. So how do we operate as a bank? We have a universal banking model that we are pegged on, where we offer our services, and that include the retail banking, where we serve you as an individual, as a consumer, either in MSME or the high net worth. I know most of you are pegged on the high net worth, so please do come to our tent for more clarification. There's cooperatives banking, where now we handle the societies and the circles. There's a Coop Trust Investments for the asset management and investment. Coop Consultancy, what we do here basically is we offer capacity building to circles, groups, and welfares. Corporate institutional banking, that is where I belong. So here we handle the large corporates, government entities like NASCOP, NGOs, and religious organizations. We have the leasing arm, where we handle your asset and equipment leasing for hospitals. If you do want to acquire any hospital equipment, please do approach us. We also have an insurance brokerage firm for all your insurance services. Kingdom Securities for stock brokerage and share trading services. So the key segments here is personal banking, MSME banking, corporate and institutional banking, high net worth, youth financial services, government and public sector, the group and Chama banking, women banking, and cooperatives. What is our key offering today? Our message to you is that we do offer digitalized revenue collection for your institutions, where we offer 24/7 fully integrated and automated real-time revenue collection. This, of course, the impact is felt in the efficiency in receivable management and enhanced liquidity, automated reconciliation. Also, in terms of payment, we offer digital payment solutions, and this enhances the payment and bulk disbursements through our digital platforms. When you're paying, when you have any payments in bulk, you can do it on your own. You don't have to go to the banks. We will offer that solution for you through our Coop Online. Sustainable health financing. If you have any assets that you want to be financed, be it vehicles, medical equipment, or leasing, or if you want working capital financing, you don't have to use your money. Come speak to us. Let us give you that freedom for you to acquire a working capital solution. We also do supply chain financing for all your invoices, LPO, and all the discounting. Mortgages. We support your health infrastructure. If you want to redesign, you want to modern your facilities, please do approach us. And we also have a product, what we call financing of health SMEs. This, of course, increases your efficiency in operations, costs, and it unlocks a working capital to fuel your business to growth and expansion. Investments. Do you have idle cash that you don't want to sit in the banks? We do offer call deposits and fixed deposit accounts at a very competitive rate. And this is a prudent cash management system that allows you to invest your money, to exchange of foreign currency for hedging solutions, swaps, forwards. You want to lock a rate in the near future. You don't know when you're going to spend the money. You have a dollar-denominated account. You can lock a rate for spot trading also. Swift payments, we are available for you. Then we offer efficient fund management for donor fund management accounts. This allows you to have a very transparent financial reporting system that will comply to most of the donor requirements. Bank assurance solutions, all the insurance services. As a doctor, you'll need insurance premium, professional indemnity. We do offer those services. Executive banking solutions for you leaders. We do offer, as I mentioned, medical practice financing, capital for your clinic expansion, equipment, and working capital. Do you want a mortgage for your facility? Come talk to us. Protection and legacy. risk mitigation, comprehensive asset protection strategies, and indemnity for you as a doctor. How do you cover yourself? What do we tell you as a bank? We're going to give you a dedicated relationship manager. You'll have a single point of contact for any issues or any clarification. Your RM will be dedicated, who will give you convenience, experience, and dedication. And also we have a direct contact center that is seamless 24/7. Why Coop Bank? We do have a strong balance sheet, an asset base of over in excess of 800 billion with a high single borrowing limit. Sector expertise, we do have a sector just handles only health in our department. So you're going to get skilled relationship managers who's going to handle you, understands your needs. Delightful customer experience with a very robust system, a wide coverage. We are in all 47 counties digitally. We do have all our presence. If not, we do have the COP Kwa Jirani. Of course, these are the awards that have been awarded to us. I'll not mention them. Thank you. And once again, I do welcome you to our tent. Feel free. Thank you very much.
So thank you so much, Walter. So you've said how much money are you giving us? In excess of millions. I hope you have it there in cash. We are all coming. So thank you so much, Walter, for that presentation. He's part of the sponsors of this summit, and we are grateful to have Cooperative Bank together with us. Now we are going to move to the technical bit, and as we do this, I want to invite Dr. Paula, we call her JP. Dr. Paula will be taking us through the cervical cancer elimination strategy. We've been passionate working together towards eliminating cervical cancer, and we are glad to have Dr. Paula, who is the head of the National Cancer Program, and she'll be taking us through this. Dr. Paula, karibu.
Good morning. Imagine presenting early in the morning on the last day of the conference. I hope your ears are still open. I was a bit anxious that, all right, I was a bit anxious, so, this has gotten messed up. Let me switch off and back on. Can you hear me? Can you really hear me? Good. Yes, I was saying that I was a bit anxious that the room would be empty, but the room is quite not very empty. It's quite, there's quite a number of us here, and I want to thank you for making this conference a priority. And I want to say from the onset that I want to give you a message and make you an ambassador, that you take the message out there. Is that okay? So I don't know how many of you deal with matters cancer, or how many of you, what comes to your mind when you think cancer? From the conversations that have gone on here, I've seen that it's generally, okay, there's been reports of progress, yes. I was hearing the survivors yesterday talking, Sally sharing her story in one of the breakouts, and yes, there's been a lot of progress, but still, many times when you hear cancer, it's not usually, it doesn't give a good, feeling. But I want to bring you a message of hope today, that there is one cancer that we can eliminate, and that the world is actually working to eliminate. And so what is our roadmap as a country towards eliminating cervical cancer? Let me begin by just saying that I come from the National Cancer Control Program. Yes, that would be a sister program to NASCOP. And what do? We do three main things in the National Cancer Control Program as the Ministry of Health technical focal point for all matters cancer, aligned with the National Cancer Control Strategy. Of course, just like the other programs, we do policy, we do capacity building, and we offer technical support to counties and to other stakeholders. And we do this through our national technical working groups and also through ensuring that we have a robust monitoring and evaluation system so that we can track our progress and inform our policies. So having said that, I want to give you a background and context on cervical cancer and then just break down a little for you the National Cervical Cancer Elimination Action Plan 2025 to 2030, which was launched very recently. So beginning with the data, this is how the picture looks. These are the global rates for new cases of cervical cancer in 2022. That is the data that we refer to. And just to keep it simple, what I'll tell you is that the dark parts of the map, the darker the color, the darker the ink, the more the number of cases. Yeah, where do you see those cases being the most? Yes, yes, yes. If I could hear what you're saying, I assume you're saying in Africa, right? Yeah, Africa has the highest burden of cervical cancer. Sub-Saharan Africa, as you can see in that map. And when it comes to the deaths, these are the deaths, they're in red. You see that the picture is the same. For us in Kenya, we have around 32.8 per 100,000 new cases of cervical cancer. The countries where that we aspire to be like, you know, like the North America and Canada and Australia at the bottom of the map, those countries have cases that are very low, probably less than 10 or less than even 4 per 100,000 new cases. And that's our aspiration, even with our action plan. So for us in Kenya, just to bring the story home, the leading cancers in Kenya, do you know which are the leading cancers? We've talked a lot about HIV. Yeah? Do you know which are the leading cancers? All right, let me tell you, because I can't hear you. Breast cancer is the top cancer in terms of new cases, followed by cervical cancer. And then after that, it's prostate cancer, esophagus, and colorectal cancer. Those are the top 5 cancers. We also have cancers in children. And then in terms of deaths, there is a shift. Cervical cancer becomes the leading cancer, and breast is number 2. Maybe you can be thinking about why that is, the issues around cervical cancer, the issues of stigma, the issues of awareness, the HIV burden. Those are some of the issues. And when we analyze the trends over time, this is how it looks. The darker bar is the new cases and the lighter one is the deaths. And you can see generally there's a rising trend. The tragedy here is that we lose 10 women every day to cervical cancer, 10 women. And I mean, this is really unacceptable, considering that this is a preventable cancer. So why does elimination matter now? And the reasons are here. Cervical cancer is one of the leading causes of preventable deaths among women, not just in Kenya, not just in Africa, but globally. And there is big disparities and inequities between countries and even within countries. And then also the HIV burden. Women living with HIV are up to 6 times, more at risk of getting cervical cancer. And yet there are proven cost-effective interventions across the continuum of care, from prevention to screening to treatment of precancer and even cancer. And then, so WHO has called for elimination of this cancer, and now there is this momentum that we have not seen before for elimination. Many countries have launched formal plans for elimination across the globe, notably Australia, Indonesia, Malaysia, Rwanda. Rwanda are talking about elimination by 2027, not 2030. Yeah, everyone else we are working towards, getting on that path by 2030, but Rwanda seem to be actually on the path, and they are targeting by 2027. And so as Kenya, we are positioned to align our national action to this global movement and to be a regional leader, as we have been in many, ways. I think many of us will agree with that, but now specifically in cancer prevention and control. So we have this global imperative, which is, condensed in this global strategy to accelerate the elimination of cervical cancer, which was launched in 2021. And it has 3 main targets. And I think if you forget anything else that I say, I would want you to remember these 3 global targets for elimination. And the first one is 90% of girls vaccinated using the HPV vaccine by age 15. And then the second target is 70% of women screened with a high precision test by at least twice in a lifetime, at age 35 and at age 45, at least twice in a lifetime. So then the third one is 90%. 90% of women who screen positive linked with care, whether it is for pre-invasive cancer or for invasive cancer. So my song to you is 90, 70, 90. I hope you will remember that, because everything else I speak is anchored on that. And so from those global commitments, we have our Kenyan response, and we anchor our response on the National Cancer Control Strategy, which has 5 pillars which go across the cancer continuum of care, and then also anchored on the National Immunization Policy Guidelines. And this tells you that, we are looking at a holistic response, and integration really is at the heart of this. So let me unpack for you what the screening guidelines say. For cervical cancer screening, the latest guideline is a 2024 guideline. And I'll start with the general population, that any woman who has ever had sexual intercourse is eligible for screening. That's the opening statement. And now, for purposes of programming and public health impact, we worked with 25 to 49 years. That is the screening target population that we work with. HPV testing is the gold standard test, and it is the recommended test. In the general population, we recommend it for women above 30 years. And then the alternative methods are still open and available to be used, especially where we don't have HPV test yet. And that is actually what we're using mostly right now in our country. For women HIV negative, the screening interval is 3 years. I will tell you about women living with HIV next. And what these guidelines emphasize, and the advantage of HPV testing, is self-sampling. Women can actually collect their own samples, as opposed to, going to a room with a health worker, and that procedure, that uncomfortable procedure that many women do not like. So HPV offers self-sampling. Okay. Let's see. I think we are back. And the other thing that is emphasized in this guideline is single visit approach, so that we avoid loss to follow up, and also integration, and especially in primary health care. And then also the other element is that every woman. Okay. Yeah, technology can sometimes show you dust. But I was saying that every woman who gets a cervical screen should also get a clinical breast examination. And so that there are those 2 points of integration that are very important. So for women living with HIV, And I think this will be of interest to us because of the conversations we've been having in this room. We start screening at age 25 years. HPV testing is the primary test that is recommended, and we really need to transition to that. And then screening interval is every 3 years. That is with HPV testing. But if we continue using visual inspection and cytology, it's every year. So you can imagine which one at the end of it might be more cost effective. And then women who screen positive are triaged either with colposcopy or genotyping or cytology or with visual inspection with acetic acid as well. And then treatment for the precancer lesions is with thermal ablation. I think we have moved a bit from cryotherapy. We still use cryotherapy and it's still okay, but thermal ablation is a more cost-effective method, and also it is easier to use. It has less logistics associated with it, and we have over 1,000 devices distributed all over the country. Then also women who are found with invasive cancer must be referred appropriately. We have several cancer centers in the country. We have the national referrals, KNH, KU, and MTRH, in addition to our regional cancer centers, which are in Nakuru, Mombasa, and Garissa. And all these centers have the specialized treatment for cervical cancer, including brachytherapy. Yes, we still need to expand on that, and there's a lot of work going on around that. And then post-treatment, all these women must be followed up annually for a lifetime. And also, let me emphasize that for women living with HIV, screening must continue for their lifetime. Okay, then now you might be wondering, are we on the path to elimination? Unfortunately, we are not currently. And you remember the 90-70-90 goals that I've talked about? So the first, on the first goal, we are at 50, but this data is 2023 when we began developing the guideline. We were at 54%. The good news is we have switched to a single dose vaccine. And now with a single dose vaccine, I think we will do better. And also the other thing is, I just want to say is that as at end of 2025, we were at 62%. So this is a bit old. But when it comes to screening, yes, we are at 41% for screening using all methods, but using which test I told you, the high precision test, HPV, we are at only 6%. And then for treatment, we have made progress from around 27% in 2021 to now we are at 43%. But what this means is that a good number of women are screened, are found to have lesions, and they are still not linked to care. So there's a lot of work to be done. So allow me to just mention that, our roadmap to elimination is really this National Cervical Cancer Elimination Action Plan, which was developed through a country-led, evidence-informed, multi-stakeholder process, and those photos are evidence of that, which culminated now in the launch, which was in January this year. So I think we have a roadmap. The roadmap has 5 chapters, and I'll invite you to look it up online. I'll share the link. And it has 3 key result areas, 21 operational objectives, and several interventions and actions. The goal is a country free from the burden of cervical cancer. And I think this is possible. This will be achieved through achieving the 90-70-90 goals. And these are the core values. I just wanted to highlight that integration is really at the heart of this document. There are three key result areas aligned with the 90-70-90 goals. So we have the first one on HPV vaccination, screening and treatment is the second one, focusing on the pre-cancer lesions, and then diagnosis and treatment of invasive cervical cancer is the last one. So I will not really unpack everything, but I'll just highlight that under HPV vaccination, our target is, you guessed it, 90%, yeah, to reach 90% of girls by the year 2030. Then those are the operational objectives, really dealing with the health system, strengthening the health system so that we can deliver on this. Then on the second key result areas, we call it Pillar 2, 70% of women to be screened with high precision test, and then 90% to receive pre-cancer treatment. Then those are the operational objectives, still aligned with strengthening the health system. On diagnosis and treatment, which is the third pillar, the target again, 90% of women with invasive cervical cancer receiving comprehensive treatment, palliative care, and survivorship care. So again, those are the operational objectives. I will let you look those up. Then the document outlines the resource requirements, and I think this is good news, and I'll tell you why. Over 5 years, we will need 1.2 billion so that we can strengthen the health system to achieve the goals that we've outlined. And an additional 1.4 billion because we need 2 additional PET scans in 2 centers. This is really for reasons of equity, because you know the north and the west of the country are not really served right now. So one will be at MTRH and another one at Mombasa. And when you consider all these costs it's only 0.4% of the total health allocation for the financial year that we are in. So relatively, these are not big costs, and overall, there are also cross-cutting benefits. When we improve diagnosis, will it only serve patients with cervical cancer? No, it will serve all patients. So then, just to highlight that currently the social health insurance, the 3 different funds have different, packages for cervical cancer, and at different stages of implementation. The Primary Health Care Fund, the tariff actually outlines all these. It outlines immunization, HPV testing, cryotherapy, thermal ablation, lip and cervical biopsy. However, the implementation was subject to funding, and I think the funding has not yet materialized. They talk about the maturity of the fund, so that's a challenge right now. However, I know facilities currently do get reimbursed for screening. And then under SHIF, that is well taken care of, and also the emergency and chronic conditions insurance fund, that one takes care of a number of costs for cancer patients. The resource mobilization strategies are outlined, and the management strategies, and one of the resource mobilization strategies, I must say, is integration. As a cost saving, as a way to improve efficiency, integration is outlined there. And there is also an elaborate monitoring, evaluation, and learning framework. So let me end. I think I have done my job. So I want to just call upon all of us to integrate, to scale up HPV testing and treatment. We need to scale up these interventions. We know that they work, so that we can reach every woman and eliminate cervical cancer. So please follow us on those platforms, and that website, that's where you can get the Elimination Action Plan. But even if you just Google National Cervical Cancer Elimination Action Plan Kenya, you will just get it, and you'll be able to look more into it. Thank you very much, and I hope you remember what I started with, that you are my messengers and ambassadors, and we look forward to continuing to work together. Thank you. Thank you.
So a better round of applause for Dr. Bor. Thank you so much. Integrate, then we scale. Women in the house, let me see you. Women in the house, hi. We are at 6%. Are you among the 6%? Food for thought. Men in the house, hi. If you have a woman in your house, is she part of the 6%? Food for thought. Okay, Dr. Bor, after this, I think you have many candidates in this room, both the women and the men. They're going to bring us their spouses, even as the women come in for screening, and I think we just need to scale it up. So thank you so much for that session. We are going to go into another session, and the next session will be looking at integration reality check, regional and county perspectives. And for this, we are going to be looking at different counties and what their experiences have been on matters integration. And to start us off, we are going to have Eunice Kinywa, the CASCO for Kisumu County. She's going to take us through her presentation. So let's have the bio for Eunice. Eunice, as you start walking towards the podium. So karibu sana Eunice. So Eunice is our CASCO for Kisumu. She's been championing matters HIV and also PMTCT. She's going to be taking us through the first presentation. So just a minute to load your presentation. You'll move with this. Yeah, your timer will be right there. So as we wait for the media team, probably Eunice. Oh, sorry. Dr. Bor has a clarification on a question that has come as we wait for Eunice's presentation to be put up. Karibu, Dr.
Thank you so much. Thank you. I went to sit down and my neighbor behind me asked me a question, and I think it's very important that I clarify something about HPV vaccination for young girls living with HIV. I just need to emphasize that the policy currently is that they are still getting 3 doses. Yeah, I know that it's a challenge, but that is where we are with the science. And that is I hope that more research will be done, and we'll see whether fewer doses will still be effective. But currently, the policy for girls for vaccination with HIV is 3 doses. Thank you.
Thank you so much, Dr. Bor, for that clarification. Yes, Prof.
We have research work on vaccination. You know, pediatricians are always vaccinating kids, eh? And for HIV exposed, for HIV infected individuals who are not virally suppressed, so you don't have immune reconstitution, when you get immunized, you're not able to sustain sufficient protection. But if you take your medication and you're virally suppressed and you have achieved immune reconstitution, you will have a much more sustained period of time where you are covered by the vaccine that you have taken. But the evidence on the ground is that you don't have the same period of sustained protection from your vaccine as a person who doesn't have HIV infection. In fact, for many vaccines, the recommendations of booster vaccines in about 5 5 to 6 years after the last vaccine, when you are vaccinated, when you're you have immune reconstitution. So our encouragement is that please take your ARV medications, sustain your viral suppression. This is the road to immune reconstitution, and this is how you will benefit from the vaccines that we give you.
Thank you so much, Prof, for that clarification. So we are going to have Eunice, and like I said earlier, she'll be taking us through the integration reality check for Kisumu County. Karibu sana, Eunice.
Thank you very much. Good morning, everyone. It is indeed my pleasure to be able to share with you the situation in Kisumu County. I wouldn't say that Kisumu County is already perfect, but we have made strides. And allow me to mention that our journey began long way back in 2022, where we developed a roadmap towards a sustainable HIV/TB program, but we were making very slow progress until that thing happened and we accelerated. So Kisumu, I would actually want to mention that it's a high burden. We're actually serving about 112,000 people on ART. I had my other colleagues mentioning that they have 5,000 in the county. That is a workload for a facility in Kisumu County. So that really tells you the burden that we actually have. So as at February 2020, when the stop work order came, we were only at 10%. So you can imagine we have a roadmap that we are supposed to follow. That was a document that is supposed to be guiding us from 2022 to 2027, but we'd only achieved 10% by that time. And really, all of us know that why do we need the change is about sustainability, very, very key, because we need to actually get out of the parallel systems. Efficiency, we have resources that we have to ensure that we efficiently use them. And again, just ensuring that we are able to align to the UHC agenda. So, where were we before? And this, I look back many years, and also as at the time that the stop work order came. Service delivery, the HIV services were separated from the mainstream MOH services. The workforce, we had dual management, we have partner-supported staff, within the same facility. The health facility in charge some of them did not even know the staffs who are actually working in their facility. And if they have to get leave, they get them from a very parallel system. Also, when you look at the data management at that particular time, we had multiple parallel systems. The main facility was mainly paper. We had some of the facilities that had already gone EMR, but again, even EMR, we also had multiples that was actually taking place. For supply chain, I would want to mention that supply chain was one of the areas that we began integration earlier, but not fully. In some of the facilities, we still had parallel systems of managing the commodities. And in terms of patient experience, I think that has been talked about ever since we began this particular discussion. There was also the issues of stigma, which was alluded to the separation of the rooms. Most of our HIV clinics were in some corner somewhere. And, when people see you going that side, then they actually know you're going for the HIV services. Then again, also, in the issues of financing services, here we were talking about free. So the free services being offered in the HIV clinic, and they were not keen. Our clients were not keen on enrollment in the insurance schemes that we actually had. So at the end of the day, that led to limited resource generation for the facility. So what did we change? Under service delivery, We are now talking about one-stop HIV care that actually moved into mainstream MOH, service delivery points, with for particular for ownership, and these again doing several models. We have 2 facilities that are operating chronic care centers, but we have others that have integrated into outpatient. So for the workforce, I would want to mention that Kisumu, I know this is a drop in the ocean, but you were able to transition 72 healthcare workers from partner payroll to MOH payroll. We know work is still in progress and discussions are going on. And then for the staff, they are now being managed under departmental heads. So it actually means that if you're working in one particular facility, you actually are supposed to be reporting to the facility in charge or your departmental head. When it comes to leave allocations, then that has to be handled through one unified system, unlike what was actually happening before. Then for the data system, we're actually talking about facility-wide EMR that has been implemented in majority of our facilities. And for the lab and pharmacy, this again were among the first easy areas that we'd begun integration earlier, but at least after the stop work order, we ensured that even facilities that had separate dispensing areas, that was actually brought into one point of dispensing of their commodities. Then for financing, we redesigned the client flow to capture the SHA registration, because you know many a times when we had those separate clinics, our clients were going directly to those clinics. They were not following the facility client flow that ensures that you pass through a SHA registration desk for you to actually be registered, and maybe your visit to actually be captured if you are a client that is already registered for the same. So this, I would actually say that is actually going to help us move beyond the donor funded care. So what are we seeing? Some of the results in a snapshot. The early wins, the service coverage, you can imagine we were at 10% integration. Today we are talking about 70% integration, where we have also 2 clinics that are operating chronic care centers. There's actually the issues of stigma reduction, and one patient who asked a clinician who had been serving in that facility for a long time. And this is actually one of our facilities that today operates only on MOH staff. We do not have a partner staff. So the client has been seeking care in that facility for a long time, and had been seeing the clinician, but the clinician was never serving them. So, and he's actually serving them so well. So the client asked that, you have been here all these years. How comes you have not been serving us? I've missed this service for all those years that you've been there. So it actually tells us that even the clients are actually appreciating what is taking place. Then for the health system strengthening, I think I mentioned the 72 that are now under county payroll. We also are talking about the integrated sample networking system that those of us who were in here yesterday afternoon is something that filled the discussion in the session that we had last. We've also had our facility infrastructure kind of renovated, because some of our facilities have recorded almost a 300% revenue increase in their revenue collection, because you can imagine about 90% of their clients are registered in SHA. So when they come in, especially the primary healthcare facilities, then they go through the registration, and they are able to be able to get their reimbursements that have actually helped. And I would want to say that even for this is what has actually improved on the ownership from the facility in charges, because they see their numbers, and if they miss them out, then actually their revenue collection is actually going to go down. And Just to finish up, my time is up. Kisumu's vision on the roadmap, we are talking about, it is not a one-time event, but a continuous process. And we actually need to be able to optimize service delivery through an ongoing refinement. It's a process. So we are using CQI approach just to ensure that we design and redesign based on the feedback that we get. We are strengthening the provider's skills. We are also looking at scaling up some of the successful models that are happening throughout the county. Then we are monitoring some of the key metrics that would actually be able to help us improve, and also just ensuring that we mobilize resources and also strengthen elements of SHA registration. I want to call us that it is not very easy to speak in a short time about the journey of integration, but we are welcome to visit Kisumu. We may not be perfect, but we have areas that we have actually done well, and Karibu Kisumu will actually be able to tell you the journey that we have taken for integration. So thank you very much, and looking forward to more interactions and also a visit to Kisumu.
So thank you so much, Eunice. We've been discussing a lot since Sunday, and what you're looking at today is a best practice. It's actually doable. So next, we'll be having the CASCO for Tharaka Nithi County, Anthony Murunga, who will be taking us through the experience of Tharaka Nithi. Anthony, karibu sana. So as he comes up, you can read up his bio, and his responsibilities majorly include policy implementation and strengthening the health systems. And he's actually served before as a county malaria control coordinator. So we are looking more into the integration of various diseases. Karibu sana, Anthony, and take us through your presentation. Please, in your time.
Thank you. Yeah, good morning. Yes, in Tharaka Nithi County, the discussion about journey to self-reliance started way back around 2018, and I think it is just like any other place, any other county, within the country. That discussion was dominating the corridors and the space of HIV programming at that time. And we were very slow to take it up, I believe, just like others. And around 2020, we had an experience of COVID-19. We started realizing that focus can shift from HIV programming to other emerging issues. At around 2022, we went to sit down and have a deliberate conversation about how we achieve self-reliance, or how we go about this journey to self-reliance. And we could agree together with the partners that we were working with that we cannot walk this journey if the model that we are using to implement HIV service delivery is donor-led or partner-led. And we thought it is very important for us to come up with a model that is county-led and county-owned, so that we can be able to walk that journey to self-reliance. And in that discussion, we asked ourselves whether for sure it is necessary for us to shift from partner-led to a county-led model. As we can see, historically, and as we are aware, historically and traditionally, HIV and other donor-supported programs, of course, operated through vertical and partner-led models. That we would agree, and we really felt that that needed to change. These models were definitely capital intensive, to mean very costly. They were capacity draining, because as the project came, we implement, and we get into a new project. The previous one would move out with all the capacity that had been invested into, and we started building new capacities. And of course, that was unsustainable. Despite the need to sustain the response, the HIV response, the reality about funding cuts was with us. And progressively, we would see the decline. So as much as we were a bit slow to react or respond to that, the reality was slowly catching up with us because the trends of donor funding was increasingly declining. So at that time, there were limited local ownership and a minimum capacity transfer. This is the time whereby the capacity to handle even HIV commodities was with the partners. To the extent that the county pharmacists would even distance themselves from managing ARVs and also TB drugs, and they would be managed by a partner supported staff in a CCC who is maybe a clinical officer or a nurse. Sorry. So we also felt at that time that whoever is working under the support of the partner has the same requisite capacity with the staff establishment that we have in the counties. And then it is at that point we decided to be intentional about coming up with a model, but of course, a well-structured, documented model that can be able to help us achieve this shift from a partner-led to a county-led, county-owned way of HIV service delivery. And then jointly, we start with our partner, USAID Jamii Tekelezi, and 3 more other counties, that is Embu, Meru, and Nyandarua, so that we discussed what kind of a model we want to come up with. That's how we got a child. That time, during the birthday, we called that child CMM, County Mentorship Model. But this later mutated to CMAT. After we started implementation and we learned about a few things here and there, we felt that the CMM that was initially conceived lacked a few aspects and components, especially bringing out some strong pillars like integration was lacking, and then we improved our model into CMAT. And of course, to explicitly bring out the aspect of transition to show that this is a vehicle that is facilitating us to transition from this kind of a model to another model of health systems in our county. So CMAT was born with all the objectives that we have seen there, with it was built on 5 pillars. We have built our model on 5 pillars. At the center of it all is to ultimately have or develop resilient systems that will obviously lead us to epidemic control without interruptions, without the disruptions, despite the emerging issues that will come our way, like the funding cuts, like the stop work orders. That should not disrupt us from achieving epidemic control. What are these pillars that we thought about? The issue of mentorship. Mentorship was conceived as one of the key pillars because of capacity transfer and continuous capacity building. And we would say that even if we were to shift and transfer the roles or change the roles from the partner taking lead to the county taking lead without a proper capacity transfer or capacity building, without thinking about continuous capacity building, is like giving someone a position that has got no power. So we thought for us to be able to achieve this, we need to have a very strong pillar on mentorship, whereby we can build on the pool of knowledge and skills that we have, transfer those skills from the partners to county mentors, and we started building a pool of county mentors who subsequently would transfer that knowledge continuously to the facility level and even to horizontally to other peers within the county. The other pillar is on advocacy. We also agreed that we cannot be able to achieve self-reliance, for example, without ensuring that we advocate for more allocation for resources and optimizing what we have, whatever little resources that we have at the county level, to ensure that it is efficiently and effectively used to assist us in kindly back. I want to focus on that slide. The rest will pass through. So the other pillar is on integration. We aim to agree that an integration pillar needs to be integrated within our model. And this is because we all agreed that we cannot have we cannot succeed in sustaining HIV service delivery if we maintained a vertical way of programming. Leadership, we introduced that pillar to ensure that the leadership, right from the top leadership to the lowest level, leadership at the facility level, we have to ensure that they are accountable, or us as the leadership, we are accountable, and we are able to steer the program and the aspiration of the program as the leader, so that this one can be able to be realized. Issues of sustainability, maintaining quality services and resilience, ensure that whatever comes our way does not interrupt the services. At least we can be able to manage the most basic package of HIV care delivery. So those were the pillars that we thought about, and they form our model, they shape our framework, they shape our vehicle into, next kindly. And during implementation, we have been able to ensure that there is co-creation of work plans and priorities. We engage the topmost leadership, like the CEC for Health, participates in the work planning and writing of proposals, so that we can always appreciate where we are and where we want to move, what we need to do as leaders to ensure that HIV programming is sustained to the extent of achieving the ultimate goal of epidemic control. Enhanced logistical support, we have been able to achieve that by ensuring that whatever resources that are there, we are able to facilitate the mentors to move out there on a monthly basis, support facilities, and ensure there is capacity that is being built continuously at the facility level. Twinning of partner mentors, that happened because we had partner mentors that time, and they had a lot of capacity that we felt that we need to tap in. We need them to transfer to the county pool of mentors, so that when they exit, which they did later, when they exit, we can be able to take up the roles that they were doing at the facility level. Progressive inclusion of more and more mentors at the county level. We started with the scarce cause. We brought in the sub-county HRIOs to be the M&E mentors. We brought in the ICT officers to be able to maintain the infrastructure of EMR and others. Then data-driven CMAT work plans. Every other month, we have a work plan, a very deliberate work plan that is data-driven. Look at the data, try to tease out where there are gaps, and have a work plan to address that through mentorship. Integration of more samples in our sample referral system, and alignment of CMAT activities. All these have happened in the process of implementation of CMAT. Next, please. What have we achieved? That is before and after. We have been able to see progressively county led sustainable transition planning. Right from the facility level, we are thinking about sustainability, even in the plans at the sub-county and also county level. Integrated county systems aligned with the local priorities. We no longer work with priorities that have come from the partners. In our plan, it is us who come up with the priorities, include them in the plan, and we co-implement together with the partners. Structure and mentorship, there is work planning, and we implement our work plans very well every other month. Yes, as we conclude, we all have come to conclude as a county that the CMAT model has catalyzed the shift from Madonna-led programming to a county ownership and accountability in the HIV delivery coordination. It is not just about coordination for us now. It is also about leadership, taking leadership in the programming. CMAT has institutionalized sustainability of by embedding HIV response within county systems. This county-led implementation approach is scalable. It can work even in other programs. It can work even in other counties. And through this model, as a county, we feel that we now have the capacity to manage and optimize both internal and external HIV resources, delivering quality HIV. We are ready for G2G as a county. That is what we mean. So integration demands ownership and capacity transfer. And the future of HIV response is county-owned, integrated, and sustainable. These can be found in the CMAT model. We invite you to the Rakanidi to learn more about CMAT. Thank you.
Thank you so much, Anthony. So as we continue looking at moving from policy to the real implementation, I want to invite Dr. Carol Mwangi, who will be inviting the next panelists and will be taking us through that discussion. Dr. Carol Mwangi, karibu sana. So a round of applause as Dr. comes to take us through the next session. So Dr. Carol Mwangi is a pediatrician and a public health professional working with NASCOP, and she'll be the one taking us through the session. Please look at her bio as she invites the panelists.
Thank you, Dr. Gladwell. Good morning. Yes, I'm happy the room is now a little bit more full. So really, as we've said, this session today is the how to do it. I think it's been very clear from our leadership. We're not talking of if, when, it is now. So we've had very, very insightful presentations from two panelists, two presenters who will also be part of our panel discussion. So allow me to invite the rest of the panelists, if you can display their bios. We have Dr. Sarafina Sikwata. a pharmacist and field epidemiologist who's currently the lead for the National HIV Clinical Support Center at NASCOP. Please give a round of applause as she approaches the stage. Karibu, Daktari. Next we have Dr. Kenneth Masamaro, a senior public health expert, currently serving as the acting associate director for the health service delivery pillar at CDC, Kenya's division of global HIV and tuberculosis. Karibu, Dr. Masamaro. I now want to invite our next panelist, Dr. Mutugi Mureithi. He's the Chief of Party for Chak Jamii Tekelezi Program, implementing partner. They implement HIV prevention, care and treatment interventions in collaboration with county government and health partners with a wealth of experience in implementation. Let's give him a round of applause and welcome. And then next is Dr. Griffin Zomondi, who is currently serving as the medical superintendent at Maua Methodist Hospital, where he oversees clinical services and delivery of high quality patient care. So, karibu Daktari, thank you. So really the focus of this session is to hear about real implementation experiences in addition to the ones that have been presented. Also listening to the challenges, the enablers, and policy alignment. I really hope that one key takeaway from this session would be that it is doable. So moving on to our first, I'll target the first question to Dr. Sarafina. So Daktari, we had an assessment of integration across the country. From this assessment that we carried out, I think after the stop work order, what are the biggest system barriers when integrating HIV services into non-HIV settings?
Good morning, colleagues, and welcome to this session. As mentioned, I'm Dr. Sikwata Sarafina. And just addressing the question that Dr. Carol has asked, the program was able to do a baseline assessment in 25 counties. And having gone around the 25 counties, it was observed that the country is at different levels of integration. And many counties have really done a great job in trying to integrate services. So we found out that there are counties that had started integrating HIV services into the major or the broad health system earlier on, even before the stop work order. But there are then others who were forced by the stop work order to then integrate some of these services. What we found out is that the country is doing well, and a few challenges arise in different sections. So we will look at the challenges in terms of the 6 pillars of health. So when it comes to leadership and governance, the challenges were that some of the county leadership had embraced integration, but some counties are still slow. You know, it's been traditional that HIV is funded by partners. HIV has its own staff. And therefore, some of the county leadership had not embraced the idea of integrating services. But there are counties that showed a lot of leadership support, all the way from the county to facilities. There's a facility in Kisumu County where we found that the integration had been done overhaul, like from service delivery all the way to pharmacy, and they were doing very well. But the initiative was from the facility in charge. So when it comes to, as a barrier, if leadership doesn't embrace the idea, then it becomes very difficult for integration then to take lead. When it comes to the second pillar on financing, it was also it was among the largest barriers. Only 1% of the facilities we assessed had a budget that was actually implemented. There are some that had some budgets around HIV, just on paper, but when it comes to implementation, money had not been allocated. So one of the barriers as we go forward is could be around finances, because the budgets are done by the counties, but when it comes to real implementation, then money is not put in. Yeah. Then when it comes to service delivery, for service delivery, we had several barriers, and one of them was around the space. Traditionally, CCCs have been away from the main facility, and they had big buildings which were well and self-contained. But now when it comes to integrating, most facilities are grappling with, do we move all these people from that space and bring them into the OPD, or do we have now OPD go to where the CCC was in terms of physical infrastructure? So that came out as one of the barriers, that there are facilities that might want to integrate, but they don't have space, because we know that the numbers for CCC are also not so few. Also under service delivery, we found out that because of now the numbers being more and the staff have reduced, so this cuts across service delivery and HRH, that we had staff who are supported by partners previously. Some have gone home because their contracts are over. Some are still in the facilities, but now they are being supported by the counties. So they have to be put in the normal rota of patients and of seeing patients. And therefore the workload has become a lot and the number of staff is less. So we found out that now it was a lot of workload, and this was now pouring into the patients. From the patient side or the client side, they were complaining of long waiting times. Yeah. So we hope that as we go into this now under HRH, we can capacity build as many staff with the launching of the new guidelines. Previously, we will start with the people who are in the CCCs, domiciled in the CCCs. But I hope this time around we'll have a new model, so that we have every healthcare trained on HIV, and also the other diseases like NCD. I know once we leave medical schools, we almost become siloed, because maybe you are seeing patients in outpatient or you are in the eye clinic, so we forget some of the other conditions. So maybe as we go out, it will be good to focus on training wholesomely, that healthcare workers may be able to manage these patients. Then on data systems, the major issue was interoperability. The facilities will want to integrate, but it seemed like you'll have to have one or more computers on your desk, so that you see a patient using the Taifa Care or Jumbo, the system that the facility is using. Then now when a patient walks in and they are supposed to get CCC care, then you have to now go into EMR to see them. So the interoperability of the systems, and also around data systems, we also found out that most facilities didn't have power backups. So they'll go back to paper, and when you go to paper, then you are not able to get or link the patient data. So that is also another big barrier around integration. And lastly, when we look at HPT, so for pharmacy, we found out that almost 50% had integrated, that they had now moved the commodities from the traditional CCCs into the main pharmacy, but still there was a lot of stigma around the pharmacy area when it comes to patient feedback, because the pharmacies traditionally are just an open space, and you know the way the ARV bottles have a lot of noise, so someone coming in to pick their commodities, and they are maybe even on the queue, their pastor is seated there, who was also a patient, and they found it very difficult. So this was also another barrier around the commodities. And lastly, just to mention that it has been mentioned by the communities in this room that they'll access the ARVs for free, but then at the same window, they'll be told, go and pay for your NCDs, go and pay for these drugs. And therefore, it was a little bit difficult for patients. So I would say summarily that integration is working, but we have a few barriers across the 6 pillars of health that if addressed well, then we'll be able to integrate HIV services into the broader system. Thank you.
Thanks, Dr. Sarafina. Has she highlighted vitu kwa ground? Is that what is happening? So, just quickly pivoting on that. Dr. Omondi, uko kwa ground. So, these are some of the challenges. And I know we've had really, really good examples from Kisumu and Tharaka Nithi. And we'll come back. I told you this is doable. They also experienced the same. They'll tell us that. But they were able to overcome these challenges. So based on what Dr. Sarafina has highlighted, what are the practical steps? Your facility, you're the in charge of the facility. What steps have you taken towards integrating services, Daktari?
Thank you so much for the question, and thank you so much, everyone. I think I want to start with the good news that we are fully integrated and it's working, and we have not lost clients. We've also maintained good viral suppression levels over that period. You can see our poster over there at the gallery. Yes, what are the practical aspects? Number one, which for me is considered the highest, is hospital management team understanding what it means to integrate and why we have to integrate. What happened is we were able to make the management team to understand the need for integration and why we are integrating, because administration support in the hospital is key. If the clinical services division feels integration is more important and the finance doesn't see it so, and the nursing department doesn't see it so, and the HR doesn't see it so, then it will only remain in the mind of the people, it will only remain in the mind of the doctors. So that is the very first thing that for us worked very well, because we were able to put this as a fact for the management team, particularly from our CEO, and also partly under duress because of the stop to work order. Most of other mission hospitals actually were able to lay off quite a number of workers. And then my boss, who is our CEO, said, Daktari, I also chair the integration committee there, and said, Daktari, work into how we are going to incorporate HR for this, all these salaries might be integrated into our system without losing any, and none of them is going home. We started with that, and it was not a very easy thing. What we did was a strategy with my coordinator. Then we did a pilot, and it's currently working. That was number one thing. Number two, to ensure that staff understand, and the clinicians, particularly in the outpatient, is organized so that you will also find there's an area where we have doctors, there's an area where we have clinicians, then we have the traditional CCC, and also we have consultant clinics. And you realize that all these have actually these patients passing through at one point. So we were able to form a training. We were able to establish 3 pathways: client pathway, and the doctor's pathway, doctors here included clinicians pathway, and the nurses pathway. And with that, we were able to make each understand. Each and every time we started during the pilot phase, making 2 nurses from what was known as OPD going to CCC, and 2 clinicians coming from CCC going to the OPD. That worked for 3 months. And by the end of 3 months, all our nurses in the outpatient and all our doctors in the outpatient had actually used both systems. That is, Kenya EMR had actually seen patients, HIV patients, and also seen the HIV and TB clinic patients. And thereafter, we also integrated with our hospital HMIS. We used the same computer. We also integrated Kenya EMR into all hospital computers so that they must not open two computers. The same person, all clinicians have access to our hospital system and also to the Kenya EMR. And that happens from triage as well. So we started with the chronic care model that has actually been embraced currently into a working general outpatient integration, and we have not lost clients basically on that. And also that was the staff understanding, clinicians, nurses, and also there's the aspect of HRH that was very difficult because we have to have these people incorporated. Of course, some funding has been cut. And now the challenge has been, how do we maintain the same scope of work? Previously, there was a CHV, there is a mentor mother, there is an adherence counselor who was actually walking to the villages. How do we then now integrate these people to also work as other hospital staff? And we were able to suggest that was actually taken. Some of them are in the institution as customer care personnel in the outpatient, but still doing the same thing as adherence counseling as part of HRH integration. And that has actually ensured that we do not have double HRH in that regard. Some of the CHVs are also used as grassroots hospital marketers, so that in the long run, for the management, they can perceive a value addition, which is very key. And there is also the other aspect of what we have done, client education. According to me, the people who are actually not very ready for integration are the communities, unfortunately. The systems are getting ready. Everyone is getting ready. But in my opinion, the communities, the actual clients, they are not educated enough to get ready for integration. You realize there is a woman who we are traveling to take to them medicine. There is no longer money that someone will take from the hospital, use hospital ambulance or use hospital transport to take to them deep in the villages. And they were also saying, mimi hospitali ndio imenisaidia tangu hii ugonjwa mwaka wa 1997 mpaka sasa watoto wangu wote wamesoma. And that comes in. So we've been also able to use client education pathways using these currently hospital marketers or CHVs. We've been able to train them and even ensure that they get some tokens to be able to educate our clients. So client education. And the last perspective is we've also integrated HIV care and all NCD care into our hospital continuous medical education programs. So as part of regular CMEs, when people come, you will realize that the palliative coordinator, the coordinator there, the TB counselor comes in, and it's not only about the test here, at least for doctors, the test here, internal medicine, surgical approaches. They also come there to listen to how many people were screened, what are we doing? And strategy for implementation is a key thing. Without a strategy, it would be difficult. We actually did a pilot for 3 months, and it is currently working. A lot of resistance. People don't like learning new things, and we have to simplify for people knowledge. And that makes me even a little skeptical. We launched 20 documents, but most people nowadays, all hard copy documents in my facility, they are lying in a cupboard somewhere full of dust, and people do not know about them. How about even implementing, thinking about an app that can consolidate all our guidelines so that we can get them at the click of a button? Thank you.
Thank you, Dr. Mondi. I think really highlighting the journey you took as an institution, the challenges you faced. And remember, our PS yesterday said if you're making changes and everybody is comfortable, then you're not making any changes. So I think I'd want to encourage you. I think that's the right direction that you're moving towards. Possibly with the guidelines that we launched, I know one of the visions that we have as the Ministry of Health and also NASCOP is the virtual academy, where we have all our training materials, our curriculums hosted, and healthcare workers, both at pre-service and service levels, can be able to take these courses, be certified, and learn about updates in the clinical care space category, all for various diseases. So thank you for that. So we've now moving to our donor and implementing partners. Really, a lot has been said about leadership and financing, and I know we've said leadership is the key. So Dr. Masamaro from CDC, there has been implementation, and I know even in the last summit we heard about various G2G or government to government arrangements in some counties. We know we were implementing that even before the stop work order. So where were we before these arrangements? How are they being implemented? And what is the current space around transition? We know there's now the big G2G, MOH USG, but we know it has been ongoing in counties. So kindly give us the perspective and the impact that we're seeing on that. Thank you.
Right, so thank you very much, Dr. for that question. Yes, G2Gs have been in existence for a very long time. If you remember, about 10 years ago, the program was at a very different space. We were accelerating to 90 at the time. I think Test and Start had just started. We were scaling up the VMMC program. There was a lot of interest in adolescent girls and young women through the DREAMS program. So a lot of things were happening. And I think to do that acceleration, it was a very vertical system. And of course, we were using our implementing partners to do that, and they did that very well. But even then, we were having conversations of, so what next after acceleration? And of course, what next is sustainability. And at the time, there were conversations of, what if we give direct funding to counties? So you pivot away from the partners and give money to counties. And at the time, I think we had a lot of discussion. We did a few readiness assessments. And at the time, CIA was the best place to start, and we did start. The good thing is that the leadership got it. They got the vision of what we wanted to do, because we were going after epidemic control and towards sustainability. So how do you give counties more responsibilities? And so what we did is that we put out a notice of funding opportunity through what we call a single source justification that was targeting CI counties, so we funded them. There was a lot of capacity building, a lot of engagements, readiness assessments. But the good thing is, as I said, the county got it. But of course, like in any marriage, there are unmet expectations. And, I think that time, and really stemming from the fact that, we are accelerating, we are moving very fast, we are used to moving quickly. The county is different, has different ways of working. They have many other priorities. And so it was not working very well as we had wanted, but the commitment was that we wanted it to work. So we chose to, hire staff to manage the agreement through those funds, as opposed to the initial vision where we would just let the county manage that implementation. And I think for that, it worked. Fast forward to 2019, 2020, the program is changing. There's now focused scale up. A lot of things like, differentiated service delivery came in, but a lot more focus on now sustainability, integration. How do you sustain? How do you give counties more responsibility? And so, learning from the CIA model, we put out another NOFO through what we call limited eligibility criteria. So what we did is that we said counties can apply, and then we'll award those ones who are successful. So we went ahead and awarded, it was Homo Bay, that was next, Migori and Nyeri. And for Nyeri, we decided, okay, we did not want to create a mini implementing partner. We wanted this to be county. So we negotiated with Nyeri County to see that their leadership at least were from the county, being paid by the county. But then the rest of the things that we are paying for, whether it's HRH, whether it is supplies, it is equipment, it's capacity building, were being funded by the funds that we're giving the counties. I think it worked very well. We were again very lucky that the leadership got it and implementation started. Then thereafter, we again now funded additional counties. So Kiambu, Murang'a, Nairobi was funded, Kitui, Machakos, Makueni, Kisii, to make a total of 13 counties. I think that a lot of lessons have been learned. Of course, counties are at different stages in terms of implementation, but if I was to look at impact, I think number one is that there's a lot more involvement, both in terms of the technical as well as the administrative leadership within the counties. So they're aware that this is a program, it has worked, but the responsibility of that program is really vested in the county. Number two is there has been commitment, financial commitment, to actually invest in HRH, invest in HIV. You had, what Eunice had presented earlier, 72 staff, out of the payroll are now being catered for by the county. And I think that is replicated in many other counties that we are supporting. I think the other thing is, in terms of service delivery, if you look at the outcomes of both, testing, treatment continuity, viral suppression, I think it's still the same as with our partners. Of course, they've had a lot of support working with our implementing partners, so it's a very collaborative thing. Counties are also taking up a lot of implementation science activities. So writing up their lessons, presenting in conferences, doing scientific products, so that's a good thing. But of course, there are still, many challenges, both in terms of, things like leadership transition and transition of staff. It happens, but transitions will not stop. So that's a challenge that we'll always have. So how do we ensure that the gains we have made still continue? I think moving forward is that we have a very good blueprint in terms of how we are thinking through the implementation of the Health Cooperation Framework, at least from the perspective of service delivery from the counties, because that is exactly how it will happen. We hope that the national government is thinking through this and ready to use this blueprint. I don't think we need to reinvent the wheel because we already have examples. We know what has worked, what hasn't worked. I think maybe the other last thing that to mention is, the G2G, we've also had a national G2G for many years through NASCOP, of course, really looking at policy ideation, implementation, dissemination, supporting all spectrums of the program. It's, I think, it's the oldest G2G, 20 years old. And I think also that is another blueprint to think about, even as you think about the national programs and how implementation of this cooperation framework will happen at that national level. Thanks.
Thank you, Dr. Masamaru, for outlining that. And I think when we say when the US sneezes, we all catch a cold, I think there's a lot of, the spotlight is on us as a country for G2G. And I think that's the direction a lot of donors will go. But thank you for that. So Dr. Mutugi, we had about CIMAT, and really fantastic experience from Tharaka Nithi. So maybe just elaborate a little bit on what is CIMAT and how it has supported the transition of HIV program leadership and ownership from an IP perspective. Thank you.
Thank you so much, Daktari. And as many speakers have mentioned, one of the key things that have come up is the aspect of leadership. And my brother Murunga from Tharaka Nithi presented about CMAT, which is a model, a pragmatic system strengthening approach that was, I would say, was conceived by CHAK, Christian Health Association of Kenya, but co-created. And I want to emphasize the aspect of co-creation. Co-created with the 4 counties, Tharaka Nithi leading, Nyandarua, Meru, and Embu, where we implement. And in this system, during its birth stages, back in 2022, we sat and asked ourselves difficult questions, and we reflected. As Murunga mentioned, that they were grappling with the buzzwords of sustainability, county-led, country-led, and owned systems. And from our side, where we are coming in as partners, we were again looking at how is the future, how shall the future look like. We are alive to the dwindling health resources available from the donor community. And therefore, one of the big questions when we start to co-create, we reflected upon and asked ourselves some difficult questions. Some of them rhetoric, didn't require us to answer, but just to provoke thought. And one of the things that we asked ourselves is, at what point did the HIV epidemic response fall out of government leadership? Now that we are saying that we needed to be county-led or government-led. And who took away from the government leadership? And at that time, what we agreed is to redefine and reposition partnership so that we looked at it as a journey that we are walking together, a journey of HIV epidemic response. And we said here we have co-drivers. We have the county, the driver, and the co-drivers as the partners. And it appeared at that time as if the co-driver, of course with expertise in driving, took the ship and drove it well. To an extent, the driver, who is the owner, took sort of a backseat. And at that time, what we did is to build the leadership at the county level, the facility level, and to inspire them. Murunga taught us about the 5 pillars of data-driven mentorship, advocacy for resource optimization. And since he took us through that, I just want to say what we looked at in terms of resource optimization. So ours was to imbue the county that indeed they have the resources. And one of the key resources we realized was not optimized is a human resource. And we said under CMAT, we are not gonna create new structures. We looked at the structures that the government has from the county department, from the CEC county directors, the technical leads at the unit. We realized they have what it takes. The likes of Murunga's CASCOs are there on the ground health facilities. And when we created the model, of course with the goal of building and institutionalizing sustainability into the system. So we made sure that as a partner, we want to enliven the county leadership, the facility leadership, to ensure that HIV epidemic response at whatever level is not sort of treated like a side, or we say maybe a side chick. We wanted to make sure that it's an integral part of the health care architecture. And at every facility, we made sure that the counties are taking lead right from the facility. And we looked at the human resource. At that time, counties would request much more HRH support. But we said, let's first of all optimize what we have. And when did an evaluation of the resources that we had and the human capital on the ground, at county, Tharaka Nithi, we said, first of all, before we start thinking of adding more HRH, how can we first of all optimize the people that we have? And it's through that systems that we created a structure that services are delivered by county-owned staff. For instance, a case in point, the entire county of Tharaka Nithi where we support, we have very minimal extra investment in other human resources. Like for instance, in the entire county, we have 7 clinical officers supported by the partner, 1 nurse, and 4 HRIOs. So to that, how did we ensure that then service quality is maintained? First of all, by inspiring Muronga and his team, and Dr. Kameti is here, the county director, that yes, with the resources that you have, we will work with your staff. At that time, we had partner technical officers. We started a process, what Muronga called twinning. We said we work with you in the initial stages where we volunteer our technical experts to work with you, do a capacity transfer, pragmatic capacity transfer. And at some point in time, we phase out. And through that, we had, in Nyandarua, we had like 8 technical experts deployed by CHAC. Nyandarua, we had 10 technical experts. And the first 1 year, 2022, 2023, where we twinned, we realized, yes, we were confident that the county have the capacity. And in 2023, we made a very deliberate and bold move as CHAC. And he said that now the partner-led or the partner experts step aside. We did a deliberate, CHAC instituted reduction in the technical support that we are giving, technical staff that we are donating to the county. To an extent, from 2023, we left only 1 staff per county, that's in Tharaka Nithi, and 1 staff in Nyandarua. And we let the county now sit on the driver's seat. Of course, we maintain a higher level TA to ensure that systems are in place and no client suffers because of maybe of the withdrawal of the partner staff. And what we've observed, as Muronga mentioned here during his presentation, is that since we had 4 counties, we were deliberate, first of all, to go full scale in 2 counties, Tharaka Nithi and Nyandarua. And because we were careful to study to ensure that really we do not do something so drastic to an extent that our clients are disadvantaged. We worked with the 2 counties like a natural experiment in Tharaka Nithi and Nyandarua, comparing with Embu and Meru, where we maintained a hybrid of the traditional way of programming. And what is interesting to note is that we have managed to sustain quality of care, minimize overhead costs. For instance, we closed all our offices in those counties, and the only 1 staff that is in the Tharaka Nithi sits with Muronga, and they're able to coordinate. And with that, what else did we do? Resource optimization. Remember what we are saying, resource optimization at the county level, resource optimization from the donor side. We are an implementing partner. We were able to secure enough resources from that move to an extent the HRH that we had used to receive, their remuneration package was way below the county level. We were able to boost their remuneration package. We reinvested the savings or the efficiencies that we drew from the system. We reinvested to an extent that our HRH are remunerated at the county rate. Secondly, we also discussed that partners, we've been here for some time, over 2 decades. We built the county to accept and to believe that their own staff can be mentors, as good, if not better, than the partner mentors that have been there. So in Tharaka Nithi, Dr. Kameti, the county director, Muronga, and the entire architecture of leadership appointed from amongst their own HRH mentors that will be able to support the scarce course, clustering facilities so that we ensure services are provided, high quality services. And lastly, the most important is looking at, we said that the epidemic does read our work plans. Traditionally, we would have a county with maybe tens of facilities or hundreds, but only a handful of them supported by the partner directly. So through the system, the counties now have been able to increase the mentorship footprint to an extent that HIV services have not been as decentralized as the other services. We mapped HIV TB and MNCH, and we realized our people living with HIV are disadvantaged because the HIV services are only concentrated in handful of facilities. So through CIMAT, the county team with higher level TA have been able to decentralize HIV service further to facilitate, to ensure there is equity. I think that's the story of CIMAT and how leadership has been able to be taken up by the counties as we continue to provide higher level TA. Thank you.
Wow, thank you, Dr. Mutugi. I think repositioning your partnership, really taking the co-driver's seat as opposed to the driver's seat. I hope IPs in the house, you're taking notes, because that is how we demonstrate integration and support and letting counties lead. Thank you for that experience. So quickly, Anthony, a lot has been said about Tharaka Nithi. I think one important nut to crack, and I was very impressed when you told me mentorship is supported by the county. I get very many calls. We cannot do mentorship. Hakuna budget. Hakuna budget. But here's a county that is supporting their mentors to go around improving quality of care. How did that happen? Because now for that to happen, you have to integrate it into your work plan, lobby at the highest level. Just give us a few pointers of what worked.
Thank you, Dr. Ari. One thing that we need to appreciate in this discussion is that something like the stop work order that happened last year and gave us a lot of pressure came in as a blessing in disguise. I would totally agree with the PS, Dr. Oluga yesterday, when he said that integration is not something that we have all of a sudden learned as an ABI. Maybe there is a good practice somewhere and we really want to practice. Integration has come through some pressure of we must take up this role as a county government, as the government of Kenya. And I sometimes liken it to a circumstantial marriage, which later it might turn up to be one of the best marriage arrangement that you did not have earlier. So we found ourselves in that situation, and we have to be responsible enough to ensure that our clients are getting the services, the quality services that they deserve, that they respond to their need. And when we were talking about CIMAT and also in the process of implementation, one of the handles that we would foresee or anticipate is how do we continue funding the activities around CIMAT and specifically integration, right from the facility level to the sub-county and to the county level, because there is a responsibility and a role at every level to ensure success of integration. And with the implementation of CIMAT, we have managed to ensure that this topic of integration of HIV services is the main topic at the facility level and the other levels. What this has done is it has ensured that when we come to prioritization, for example, of the activities and where we need to invest at the facility level upwards, we always remember the areas of priority so that we can make our integration a success. And because our budgeting, for example, our budgeting process is a bottom-up approach, whereby we come up with the priorities at the facility level, and they are consolidated at sub-county level, and again at the county level, we get to the final consolidation. We have managed to influence the prioritization of HIV integration at the facility level. And you realize that every facility that is offering HIV services, in their annual work plan, in their budget proposals, there is an activity about HIV integration. And it became more stronger and more prominent last year after the signal from the US government. And that's why I say it's a blessing in disguise. So like the current budgeting cycle, there are a lot of priority activities and projects that are geared towards ensuring that we are able to actualize CMAT in every facility, in every sub-county. And the good thing also is that Tharaka-Nithi has managed to get an FIF Act enacted towards the end of last year. What a good time for us to have this act. This is because we'll be having more funding or more funds available at the lowest level of implementation, so that now we can be able to fund these priority activities that are well captured in our annual work plans and in our budget proposals, even as we leverage on the remaining minimal partner support, but well aligned with the AWPs and our budget proposals. Thank you.
Thank you. I think it deserves a round of applause. My personal opinion is that we do not suffer from shortage of money or lack of money. We are afflicted by lack of prioritization. And is aptly put it, prioritize your agenda and it will be funded. So Eunice, as we round this up, I think from one of the highest burden counties, it is extremely commendable, the journey that you've shared, that you're at 70% integration. There are counties here that are where you started, and they probably have 1% of the burden. So please just give us the key take-home messages that you'd give these counties that are still trying to figure out where do we start. You've clearly outlined the journey. And I think for those who love benchmarking, possibly Kisumu should be on your list to visit. So please just give practical, simple steps as we wind up.
Thank you very much. Yeah, I think one point that is very clear is integration is not a one-off event. And if you could utilize CQI approach, then you're always planning, you're always doing, you're always studying and getting back. So it's not a one-off. And very important is start with simple system redesign. You don't need new buildings. The only thing is you need to understand, what is my client flow? And what is the proposed flow for integration? Start. Learn lessons. Even us, it's not one-off. We did some, we went back and said, hey, haifanyiki, then you redesign again. So you keep on improving over time. But start with simple system redesign, which means you understand your flow. My client flow may not be your client flow. In the same county, client flow in facility A may not be the client flow in facility B. So CQI approach, work through the flow and redesign and see what happens. Second, for human resource, build cohesion, not just competency. I know we've talked about competency, very important, the twinning. And for us, what we were doing is the twinning was between the general clinical team and the HIV clinical team, working together. Show me your way, I show you my way. We learn from each other. So cohesion is very important because we have this notion of us versus them, you know, MOH versus partner. So when that is still there, things will not work. Joint meetings, joint plannings, I think that has been talked about. So you need to be able to have one unified team that serves the interest of the patient, a people-centered approach. The other bit is about the metrics that you need to monitor. Have some metrics that you monitor the service uptake, the quality of services that helps you improve over time, that use your data for decision making. It actually guides you in terms of what you need to be able to undertake next. And I think Murunga has mentioned, use crisis as a catalyst. Hakuna kesho, hawako, what are you gonna do? It has to work. And I think our PS mentioned, it has to work. We have to integrate. So look at that formula that would actually work for you, because for sure, the government has to lead. So there is no other way. You're not gonna sit that, Chuck is still here, CHEB is still here. Say they are not there tomorrow. What are you going to do? So crisis as a catalyst to actually be able to help you out. And lastly, and very important, scale up what works. Replicate those successful models to potential facilities. Because you know you may have a successful model that you want to come and replicate in my facility, but it's not potential. I'm not a potential site for that. So which means that you really have to understand. So that is in brief. Thank you.
Wow, thank you. Thank you so, so much to our wonderful panelists. Lazima iwak. I think that's the take home. It has to work. And as you said, not a one size fits all prescription, but tailor make, know your client flow, know what works, what doesn't work, evaluate, redesign. So moderator, I'll seek guidance. Do we have time for a few questions? 5 minutes for questions. Somebody please help me. There are quite a number of them. It's okay. So we can take 2 or 3 questions, please.
Thank you. Very quick observation. And say, I'm happy we're going where we are going because that's where we started. And we need to guard the situation where when somebody comes with the money, we drop everything and follow what they say, because I think that's what happened. Yes. And there are publications from the scaling up of PMTCT in Africa, and you'll see that it was government-led. But now, what I want to observe is that I led scaling up in 17 districts. And we worked with the district health departments. And the learning curve for every district was the same. You know, the same mistakes, and then we are right there. I mean, we've gone back and looked at what skills did people need. And I think today, my friends, even the gentleman from CDC, we can actually make a list of basic skills that that county health department requires, and the health workers require. What we are being told here is about SIRE. You know, flow, looking at data, looking at patient flow, etc. And because we know what works now, what are the core things that work to hold the teams together, we need to package it so that we can train people on it before they even get to the workplace. And one place that we could place this program, and it could have impact not just in health sector, but also in other sectors, is the Kenya School of Government. We know that to be promoted beyond a certain level, you must go to Kenya School of Government, right? And if we place that there, because these are leadership lessons, then we'll actually can give that engine, that integrator we're being asked about. This could be the injection into our country to allow for this scale up that makes us be successful. Now, on the question of that one HIV infected person, that one grandmother who lives in a remote place, please don't expect her to come to a facility. But we have a network of highly efficient and very knowledgeable pharmacists in this country, between the graduate pharmacists and the pharmtechs. And what we did in the past was that the pharmacist maybe at the county, what is now county hospital, would know where every person who has HIV and needs their drugs lives, the nearest facility, and they would pack their drugs for them and send them to that facility. And in some parts of Kenya, the health worker who works there, nobody visits. I remember in places called Cuso, we used to go, and you find a health facility, they say, the last time somebody visited here was 10 years ago, 15 years ago. And they rely on coming to the central facility to collect supplies. I don't know whether we still do that. But we worked with that and made sure that when you come to collect supplies, one of the supply you get is a CME on how to do things, right? So that you go back, you've collected your supplies, you've also learned what to do, and you're also reaching the person who is far on the ground. On the question of experts, again, this was colonialism. We've been colonizing our fellow health workers. The fact I'm a pediatrician working in the university doesn't mean that I'm no way more than a pediatrician working in the provincial hospital or the county hospital. We passed the same exams. So our principle at that time was to build that county team or district team to be mentors. Mentor within their own institution, and then mentor the health center and the dispensary, and to go there. You're supposed to go and inspect. So when you're going to inspect, you do the whole job. This is the principle of using the resources that we have. The other is that not everybody likes mentoring. See, everybody sorry, I'm talking too long, but not everybody likes mentoring. What we used to do is ask who's interested. And we found people in all different departments. The surgeons like going down there. You don't expect a surgeon to be involved in HIV medicine, but they enjoy that. They enjoy coming in to participate where they can participate. So the medical officers, sometimes it's the occupational therapists who are very good, some of them very good counselors. So we would ask volunteers to be part of that mentorship for a delivery of the HIV services in a facility, and then you facilitate that they can be able to go to the ground. And when they go as a team. So an interprofessional mentorship team, going to the ground, meeting the people down there, supporting them, but also demonstrating. You remember, medicine is a competence-based kind of thing. So you go and sit in the clinic with that person and demonstrate how things are done. And using that methodology, we are able to scale up. And I think these are some of the nuances that we need to build into this integration. Yeah. Thank you.
Thank you.
Thank you. Mine is a question to both Tharaka Nithi and Kisumu. One, I didn't hear. You've said the good work, but I'm sure you don't use stones. So has this budget been put into place? Kisumu, I'm aware that you have a good governor, my friend, and he will be able. But the day he goes, somebody else will come. The Rakanidi, you said you put it in the financial thing. That is very good. Then lastly, none of you mentioned how much you are putting into prevention. You know, you understand? Yes, treatment is prevention, but how much as counties are you doing to put in prevention? Most of those who are, I mean, Kisumu, are the younger people. So I think it's important while doing the treatment is also to try and see how to stop.
Okay, last question.
Hi.
Very last question.
Thank you. I've listened to the county experiments and of course also implementation of integration. Really wonderful. And of course, I liked exactly the example given by Dr. Griffith Omondi there on how the integration is basically done within the facility. However, I was wondering exactly if at all, let's say the facility management teams are also integrating the perspectives of the communities, because I find that of course the speed of integration, we might move so fast. Yes, I know exactly the government should basically be on the driver's seat, but of course, where is the community? And of course, also to emphasize Kamau's point, I really think that prevention is getting lost somewhere between, like, of course, we have the testing, and of course, we go to basically sustaining the treatment gains. Where is prevention somewhere there? Thank you.
Okay, thank you. I think we can now let our panelists answer. I think from Prof. Ndwati was more of comments. Kisumu?
Thank you very much for those pertinent questions. And there was the issue of the prevention. I want to be very honest that when the crisis came, the crisis was more in care and treatment. Yes, a lot of our efforts went to ensuring that we sustain our clients on treatment. Doesn't mean that we have left prevention. We are also making those baby steps in prevention, and we actually also have steps which I believe that in our next engagement, then we can also be able to demonstrate the steps that we are making in prevention. So we didn't leave it behind, but we put our attention into the emergency, which was the care and treatment. But we also have steps which we are undertaking in prevention. So be rest assured that in prevention is actually a part of our agenda, and we are also working out on very clear structures using the existing community structures that we can integrate our prevention into. And I believe that that's also something that we are able to demonstrate in the next engagement. The communities, for me, I would want to say that we are engaging with the communities, especially when it comes to the issues of the system redesign. If some of you listen to some of the presentation that we had one of our facility, Muhoroni, doing a presentation here. In the redesign of the client flow, they actually engage the representatives of the community within the same. I know that may have not come out clearly in our presentation, because I said that journey, that process we have taken could not be fully elaborated in the 7 minutes presentation that we had. But yes, they were. Thank you.
Okay, thank you, Mr. Kamau, for the question. Again, I would say prevention is one of our key areas in HIV programming in the Rakanidi County. As much as it might not have come out in the presentation, we realize that we are very keen on ensuring that we don't lose the gains in that we had in prevention programs. Like, for example, the key population program, where we were operating at ICE in Chuka Town. we realized earlier, we read the signs earlier, that if we continue with that kind of a model, we might not be able to sustain these services. So what did we do? We started thinking of what kind of integration model can we adopt for the DICE. We end our DICE co-located in the Chuka County Referral Hospital and also led by county government supporting staff. And this really worked for us because it happened before the situation came into what it is. And currently, we are continually able to run our DICE as a co-located department within the county referral hospital, as well as also building more capacity to have KP services supported in various satellite facilities within the county. We also have in our priorities the training programs for the CHPs. Because we have a high coverage of CHPs within the county, we are leveraging on that. We are building their capacity to address issues of prevention at the community level. Actually, recently we end 2 trainings to ensure that they got the capacity to address the issues of prevention at the community level. So surely prevention is also key in our agenda.
Thank you. Dr. I think there was a question on the integration and the facility experience, Dr. Omondi.
Okay, thank you so much. Just to answer his question, two questions, particularly in these select populations that live so far. We have to say that we have to contextualize every information. Where Moa Methodist Hospital is located, we usually call it a terminus. The only way you can move towards quote-unquote civilization is towards Meru Town. We are bordered into what they call Jangwa, the national park, into the remote areas of Somali and other tribes. So you realize that for a bigger part of 270 degrees, you're actually covering very, very, very remote areas. And you have to consider them as a key part. Number 2, involvement of perspective of the communities in the client flow pathway is something that we actually did. One of the things that made it success is that involvement. And we've not only involved them, we've involved them, implemented, and listened from them from a feedback perspective, which was also very positive. Yes.
Okay, thank you. I think maybe just an opportunity, Dr. Sarafina, some 1 minute closing remarks, Dr. Ken and Dr. Mutugi.
Thank you, colleagues, and for the insightful discussion that has gone on this panel. So mine will just be that as a program, we really want to support integration of HIV services into the broader system, but we take cognizant of the fact that communities are the center of it, and will do as much involvement to engage them. And as I mentioned, the barriers that we've observed from the baseline assessment, we hope that each one of these barriers will be handled. The counties are different, and as we all know, health has been devolved. There are things that other counties will embrace faster than others, but we hope that as a program will support each of the counties at their own pace to ensure that all recipients of care get quality of care services. Thank you.
Thank you.
Right, so I think for me is to say that it's possible. It can be done. We have a lot of experience. We have a lot of lessons on both the successes and the challenges of integration as a pathway to sustainability, but also on the how to do it, the modality of how exactly it works. And from the perspective of G2G, I think from a service delivery point of view, we have a lot of lessons to share. So even as, you know, the national government thinks about implementing the cooperation framework, then the voices of counties need to be very active and amplified to share experience, to, you know, to share that we don't need to reinvent the wheel. I think let's keep on sharing, let's keep on speaking, you know, so that then we're able to sustain our programs. Thank you.
Thank you.
Yeah, maybe mine as a closing remark is just to encourage all of us as Kenyans that indeed we have what it takes to lead in the epidemic response, to be able to offer our services within an integrated architecture. It is possible for HIV services to be provided at the lowest level facility so that there is no inequity in access to HIV services, just like we want to ensure that all the other services are available to and accessible to Kenyans. Yes, we have what it takes.
Thank you. So a big round of applause to our panelists, and I'll invite them to the podium to take a photograph. Nicholas and Dr. Ruth also join us so that we can take a photo, as I hand back the microphone to Dr. Gladwell to guide us on the next session.
As they take the photo, we want to end the morning session at that. So we are going to give them a round of applause. And now that Dr. Masamaro is here, we are going to do that clap that he started with on day one. So Karabanda, Senorita. Thank you so much.
I was told that was a corrupted version. We are busy consulting the author on the right version.
Thank you so much. So today, being our last day, we are really trying to catch up on time and just making sure that we have a half-day session. So we are going to give us 20 minutes so that we are able to break for tea. Then you're going to get back for the last 2-3 sessions. So I'd kindly request us to keep time. So let's take 20 minutes and be back at exactly 11:20 for the final sessions of today. Thank you so much. Please, let's proceed for tea. Thanks.
Let me confirm. It's not yet. Hello, can you hear me? Yeah, I'm standing here and wondering whether I fit the shoes, because the person who should be presenting is so tall and wears such a big size of shoe that I don't know whether I'll fit in, but I will try. He's the father of Ampath, Professor Kimayo, but the father in him, he's saying he wants to start with succession planning, and part of it is allowing us to present. And I believe with that kind of leadership that he's building within Ampath, we'll soon be able to see more and more Ampath beyond even the western and northern region where Ampath is. So Ampath, I'm sure most of you don't know that Ampath is actually an acronym standing for the Academic Model Providing Access to Healthcare. So it's not just a word, but it has an acronym, and we are living to the spirit of leading with care. It is a consortium, and it's under the auspices of Moi Teaching and Referral Hospital, Moi University, and Indiana University. So it's actually premised within the government.
And the reason why AMPATH is there was basically to try and bridge some of the bureaucracies that are there within the different institutions so that it has one unified way of being able to approach the programming, the research, the care that we provide for the over 24 million people in the Western and North Rift region. Our vision and our mission actually weaves into the true north of the three institutions, with Moi Teaching and Referral being a service delivery and a care center, with their true north being providing specialty care and being a global leader in that. Moi University, Center of Excellence for Education, Indiana University supporting the health systems and the leadership aspect, all coming together, bring the AMPATH, whose actually vision is to be able to provide specialized care to the underserved within the Western and North Rift region. And our priorities align to the three, which are mainly to be able to train, to provide care, and lead in research. And we have lived through these for the over 20 years that AMPATH has been implemented. So AMPATH in Kenya was the mother, where, as I've said, has Moi Teaching and Referral Hospital and the Moi University and the Indiana University. And through it, we've been able to scale beyond the borders of Kenya with the AMPATH model. And now we have the AMPATH Ghana, still leaning on the same model, which works with the University for Development Studies, Tamale Teaching Hospital, then Ghana Ministry of Health and Ghana Ministry of Education, just like the AMPATH Kenya. Then we have also AMPATH Mexico and AMPATH Nepal, which are still working on the same premise. When it comes to integration, it is at the core of the AMPATH programming right from inception. So we've been able to implement integration through our different approaches and in all that we do. For integrated care, which we serve clients with infectious diseases, HIV being the leading. We also support TB services, both in care and programming. We have NCDs as the non-communicable diseases. We also support cancer, mental health, among others. So we are just not having a one disease approach, but looking at a patient holistically and being able to address any concerns that come with the patients, including social determinants of health. Under the AMRS, also called the AMPATH Medical Record Systems, initially it was built looking at the HIV data. But right now we've been able to expound beyond that for quite a number of years. We are also having the AMRS be able to cover aspects outside HIV. It's covering the non-communicable diseases, the cancer, the malaria patients we are serving, the family health, maternal, neonatal, and child health. The AMRS is able to look into all that. And we are also able to have all these data relayed to the National Data Warehouse through the DHA Superhighway, which is one of the strengths of the AMRS, just ensuring that you are able to support all the facility-wide points, and at the same time, the data is available beyond the AMPATH itself up to the national level. For the community, we work through a lot with the CHPs in the counties that we support, more than 6 counties, and at the same time, we work through all the diseases. We have the CHP screening for NCDs, prevention of diseases, and follow-up of the patients with NCDs and the infectious diseases through their management at the community level. So we support at the facility level, at the same time extend to the community level, working through the government systems, which are the CHPs. Research and innovation is one of the areas AMPATH thrives in, with more than 1,000 publications. So we are only not implementing, but we are making sure that we are going beyond that and sharing the practices, sharing the knowledge we are getting from the implementation, and being able to replicate it beyond. We have over 1,000 publications when you look at the different journals globally that are published from the AMPATH data. Then the digital health, we are also not remaining behind. We have POCUS, which is a point of care ultrasound that is now in around 3 counties within the AMPATH region, and this is also being expanded. And not only that, we are also having machine learning where we are able to predict some specific indicators for the clients and be able to see what is this information telling us and how can it be able to improve patient care. So these are the different AMPATH programs. Under the infectious diseases, we have the HIV/AIDS, which is one of the largest one single program that is managing hundreds, thousands of patients. We actually have 127,000 patients under the AMPATH care. We also have the TB, malaria under the infectious diseases, in addition to also looking at the microbial stewardship as one of the programs we are supporting. Under women health, we are also supporting MNCH, as we've mentioned, and this also goes beyond the facility level all the way up to the community level, where we have like Chamas for Change. We are using the CHPs and the mothers at the community level, empowering them, having microfinance with the groups, and using those as forums to empower the mothers so that they're able to take up the MNCH interventions for good outcomes. Chronic diseases, we are having a number of programs that are looking at diabetes, hypertension, mental health, cancer, and not just treating, but ensuring that these clients are also restituted back to the community, especially the mental health, because it's one of the areas that is neglected, but we're making sure beyond giving them treatment at the facilities, we are also working to having them integrate back to the society in a meaningful way. Cancer, we have the Chandaria Cancer Center. I'm sure most of you have heard about it, where we are looking at different cancers, the breast cancer, cervical cancer, among other cancers, and we are able to provide the screening and the management and follow-up for these clients. And this is not only at one-stop shop at the Chandaria Cancer Center, but also through a hub and spoke and outreaches, it is able to service the whole of the Western and the North Rift region getting the services. Surgery, we've had a number of specialized cases being done at MTRH. I'm sure most of you have heard about them, and also in targeted hospitals within our catchment areas where they get out and get the services with the specialties and specialists from MTRH. Specialty care, I've also mentioned about it, and we go beyond just the care to include the research aspects of it and scaling it beyond the one facility, mother facility, MTRH. Childcare, we are helping children survive and thrive, including all these conditions mentioned right from the neonatal period through to any children who are having cancers. We are integrating them into the programs and being able to provide them the care needed. And then not only are we looking at care, as we've told, as I've mentioned, we are also looking at ensuring that these clients are being supported to address the social determinants of health, and most of them being the financial that hampers their access to care. So we are supporting them and empowering them in a number of economic activities, especially the agricultural activities and other microfinance like the Chamas and other small groups through which they have been empowered, because we believe health is wealth and wealth is health. If you are healthy, you can be able to look for wealth. And if you are wealthy, it's only because you are able to take care of your health to continue generating even more wealth. And then support services, we have quite a number: revolving fund pharmacy, radiology services, where we have trucks, X-ray trucks that are able to move around to provide these services beyond the main facility where they are hosted. And through that, we are able to support around 126,492 as at the beginning of January. We've supported the reach of testing, HIV testing, for more than 2 million clients, identified just for these 6 months from, not 6 months, financial year, because we are supported by the USG, so our year starts in October. So from October to around January, we've already been able to identify 36,660 clients positive and linked them effectively to treatment. We've been able to initiate 56,926 clients on PrEP, and with the LEN being rolled out, some of our counties are also priority. We've already trained the healthcare workers and looking forward to leading in providing the PrEP to the community. Pregnant and breastfeeding women also have been able to reach to 14,534 through all the way to making sure they're getting the EID and prophylaxis for their infants. For the non-communicable diseases, we've been able to sensitize the community using direct, that is around 702, 539 clients. And this, by direct, I mean when you take a single patient, a single either patient or the community, the CHPs at any one time. But when you look at the contact sessions, whereby a CHP can be trained on malaria, then next time they're trained on MNCH, because they're working through all these, we've been able to have 5 million 593,000 contact sessions. For diabetes, we've been able to screen 248,000, out of whom those who've been identified and are being managed for diabetes are 13,662. Breast cancer screened 14,000, and those where we found abnormality and are managing at 103. And when you go across all the way up to hypertension, we are managing 38,553 in the 6 counties we are supporting. And the training capacity building just for this 4 months period, we've already been able to reach 1,042 healthcare workers and 896 CHPs. When you look at the facilities, we also don't just look at the capacity building in terms of the CMEs or the trainings. We also ensure that the facilities are capacity built and equipped to be able to serve the clients. So we've been able to equip around 113 facilities with BP machines, hytometers, X-rays, the digital X-rays through the support of the US government. We've also been able to procure for them pulse oximeters, among many other equipment across the 113 facilities. When you look at the facilities, and that has been discussed even during this conference, drugs availability is still a challenge. Where you are having a number of our facilities having shortages for the different drugs, especially the NCDs. AMPATH came up with a model, the revolving fund pharmacy, where they give a seed to a facility once they have done the stakeholder engagement, they have sensitized, and the facility has agreed. So they provide a seed money for the drugs that are mostly needed by the clients, commonly prescribed, and they identify a space within the facility and a facility staff to be able to man the revolving fund pharmacy. And once that is established, what is advised is that the facility will always have this pharmacy after the main hospital pharmacy, so that if a drug is missing within the main hospital pharmacy, instead of a patient being sent outside the hospital to buy the drug very expensively, the revolving fund pharmacy is just next to the hospital pharmacy, and the clients are referred and are able to buy the drugs with a very minimal markup, just to make sure that the drugs are able to be procured again. So it's revolving because once we give the seed money, the hospital manages that account alongside key people within the AMPATH, so that the funds go back into procuring more drugs to stock the pharmacy. So they buy, then the money goes back and procures more drugs to stock the pharmacy. And once you give the seed money, there's nothing more needed because it keeps on supporting itself as the drugs are bought, and then you get more money to buy. So with this, we've been able to assure 93.8% availability of all the needed drugs. The clients in the hospitals with revolving fund pharmacy, they don't have to go out there to look for the drugs, but they have them within the facility. Then one of the projects that is also supporting, as I said, wealth is health and health is wealth, is the Big Peak project, where Big Peak stands for Bridging Income Generation through Group Integrated Care. With this, we are able to put patients together in the community, and not really patients, all the community members after sensitization by the CHPs. Then there is screening. And when you are looking at screening, if you're found not to be having any of the non-communicable diseases, preventive messages are passed on to make sure that you're going to continue with a healthy lifestyle to avoid these non-communicable diseases, while the ones who are identified to be having are linked to care while still being part of the group. So they are linked to a microfinance group where they're given a small loan to be able to do an activity of their choice. They invest it in anything of their choice. I give one example. In Bungoma, for example, Landa Webuye, they were able to start a poultry farm. And through that, they're able to generate income from themselves. And then with the income generated, they're able to keep on loaning each other while maintaining the initial fund stream. So integrated education is there within the Big Peak groups, where health education and agribusiness is also provided during the group meetings. And then those who are identified to be having any conditions, the care is taken to them during the groups. So unless it's a difficult case that needs maybe like some testing and all that that can't be done at the community, that is when they are referred at the hospital. But otherwise, all of them get care at the community, including testing for glucose. It's done at the community BP machines. So they get out to reach them at the community level. And then there's economic enhancement and sustainability, because once the loans are there, they're able to build themselves. One lady was saying that she started off with getting a small loan of 100,000, and right now she's taken even around 1 million just from reinvesting back and being able to grow. And through these groups, we are able to generate demand for care through incentives, because they know the benefits, and at the same time, they're able to take care of their health. POCAS, as I'd mentioned, we've started off in Bungoma, and right now we are having around 144 POCAS deployed across 117 facilities in Bungoma, Elgeyo Marakwet, and they're able to facilitate early screening and diagnosis for pregnant and breastfeeding women, among other conditions, by the providers. The nurses have been trained so they don't have to travel all the way to look for an ultrasound, and it is a screening, and then those who have detectable or something that is suspicious are referred for an ultrasound at the facility level. So AMPATH is actually leading in integration through all these, and we continue to champion the same, both at the counties we support and at national level, and we ground ourselves in local practice and research that we're able to share and disseminate, and also ensuring that our communities are getting the best of care by embedding all that we do in the PHC platform, and positioning ourselves strategically to be able to inform both national and global policies by sharing the data that we get from the facilities we support. And one of our great successes is the great collaboration we have with the counties we are working with, always aligning to the systems and continuing building the systems of the county. Thank you so much, and I would just like Prof to stand up and wave, because he's the father of AMPATH, so that you appreciate. Thank you.
So good morning, everyone. At least I'm standing here and you can see me. I thought I would, anyway. So we've had a beautiful, very insightful session since Sunday when we started, and we are almost bringing it to a close. But before we close, we want to hear some parting shots from some of our leaders, what we have been able to speak about, also drawing from their own experiences and encounters in this space, and also just trying to bring it all together and tell us what next, what's the way forward in terms of integration, sustainability, and just having, you know, all of us work together as different stakeholders in this space. So to bring this discussion up to us, I'm going to call Dr. Ruth Kapanga. Sorry, I didn't introduce myself. My name is Dr. Nelly Pato Dindi Okello. I work in NASCOP. I lead the Vertical Transmission Prevention Program. I'm also going to call Dr. Ashiono Evelyn, who are going to be our moderators for what we are calling a fireside outlook. Karibuni.
Yeah, welcome once again to this final session that you're having. And Dr. Ruth, we've had a very exciting 5 days where we've been able to learn a lot. We've been stretched through some of the days going beyond the 5 p.m. We've been able to share practices. We've been able to hear what the other people are saying, and we've been able to be renewed. This is quite an excellent session. And I think from here, we are going to walk away with a lot that you're going to change in our workplaces.
Yeah, I think we have learned a lot, and we have seen that actually integration is working, and it is going on across our different facilities, across the different counties. And we have also seen that this time, compared to the last time when we were meeting for the Integration Summit, that counties and facilities are actually tracking and measuring some indices to ensure that health outcomes are not disadvantaged as we are integrating. We have also been challenged by our leadership in our individual capacities to make decisions and implement interventions that will advance the integration and sustainability agenda. We have learned several things across the different days, Dr. Ashiono. On day one, we had the prevention with the LENCAP. I don't know what you picked from that. Maybe you can just highlight.
Yeah, very true. And in that session, it actually brought out the reality that science is here with us. We now have LEN, something that has been long awaited for. It's no longer about the daily pill, but it's about ensuring that our clients are supported. And with this, we need to look forward into having not just the innovation, but we need to match it with access. It's right now in 15 counties, I think, but we need to move beyond that. Equity and the system readiness across all our 47 counties is very important. For me, one of the clear lessons that came out was prevention must become simpler for the community, smarter, and more responsive to the lived realities of our community.
That's interesting, Dr. Ari. I like the fact that you're highlighting that now we have more options so that our communities can access services that are convenient for them and simpler for them. On day two, we had a lot of discussions around money and leadership and governance. We were challenged to think about a diagonal model as opposed to moving the system from what was initially parallel and making it horizontal. We were challenged to think about a diagonal model. We were also challenged to think about a transition period of tandem breastfeeding so that we optimize government to government funding. On the following day, Dr. Ari, we talked about HRH, and we also had conversations around communities. What are some of the highlights that you picked?
Yeah, one of the most important things, and given that it's one of the sessions I chaired, HRH, the health workforce, is the backbone of integration. We cannot talk about integration without actually bringing the health workforce to the front. And among it all, when you're talking of a resilient workforce, it's not just about ensuring that they are there, but we need to provide them with a good environment to be able to work. It's not about the knowledge that they have learned while they were still in school. We must continue giving them through the continued capacity building. We must also ensure that their competencies are right. They're having the right skills to be able to provide integration. And not just that, they must be well motivated and protected to serve. The workloads have to be considered. From the community, we must listen to their voices. And we must make a change. Change is sometimes uncomfortable. But when you look at the realities that are there, the one thing I liked from Nelson, who is the community lead, he said self-care is important. So we need not to always look at what is it I'm getting from out there, but I need to empower myself to take charge of my health. So owning the health as part of healthcare is one of the take-home messages I took from the community.
Fantastic. I think one of the things that I also picked was around the tools of trade. Now for the HRH, as well as for the communities, we need to be able to have commodities within our facilities so that they are able to access services. It was very interesting to learn that we actually have in-country capacity for local manufacturing of drugs and commodities. We also have learned that KEMSA is working towards reducing the turnaround time from order to delivery to less than 7 days. Unfortunately, we also learned that we still have quite some debt from the counties to KEMSA, which might affect some of the operations, and we hope those are some of the things that are going to be resolved as well. We learned that drugs for non-communicable diseases are actually now available in primary care facilities, and that the TB program has done quite a lot with regards to ensuring that TB drugs are procured through government modalities. When we looked at health information systems, I think the panel really brought out clearly that we are working towards a future where the end user will interface with a system that is seamless for service delivery, where there will be one record for one patient. And they also reassured us that the many years that have been that we have had systems, especially for the HIV program, have given us experience that will enable the country be able to move forward with regards to delivering an efficient system for service delivery. Yes.
Thank you. Service delivery brings everything about integration together. And through the keynote speaker and the sessions, the breakout sessions, it actually brought out that integration is already working in one way or another. And one of the things we're able to learn is that not, depending on the context, the integration approach is not going to be the same. But we have to understand that now vertical programming has come to its end. Actually, I was about to say near end, but no, it has come to its end. And so with that, we have to stop looking at a patient along disease lines. You know, sometimes when a patient comes in, we break them into so many pieces. We forget that this is one patient who has come in. They may be having malaria at the same time, HIV at the same time, diabetes. We don't have to break them into the many pieces, but look at them holistically and manage them holistically. And yes, it is working. This was demonstrated in the breakout sessions. It was demonstrated in the keynote speech. But what we have to remember is that for this to be successful, all of us have to know that integration is not an option, but the way forward for this. Thank you.
Thank you very much. So to help us wrap up our sessions and to bring it all together, I would like to invite a few discussants who will give us the way forward with regards to integration and what we are going to do moving forward. So Dr. Shiona?
Yeah, we have got very rich insights from key people we want to invite on stage. Dr. Katana, please come on stage. Dr. Valerie.
So
then you have Dr. Murugi.
So our panelists, I don't think we need to introduce them. They have been here. We
Yeah.
know them. They are they have been very influential in the HIV space over the past years, and we hope that we'll be able to get very rich insights from them with regards to the way forward for sustainability and integration.
Thank you. So continue. Mr. Nelson Otoma, please come forward. Then we have George Karoki, our CEC from Kirinyaga, who is the deputy CEC for the caucus. And last but not least, our head NASCO, Dr. Mulwa. Dr. Nelly? Okay, because I was looking around and Dr. Nelly has actually confirmed he's not here. So, Newton, allow us to ambush you. Please come forward. Thank you.
So thank you very much for joining us for this winding up discussion. I'd like to start with Dr. Valerie. Dr. Valerie, you have been within the space for several years. You have attended the sessions during this summit. You were here during the previous summit. What are some of the takeaways, or what is the way forward for us as a country with regards to integration of services?
Good morning, everyone, and thank you, Dr. Ruth, for giving us this opportunity. Over the past few days, there's a lot that has been shared in terms of success of what it takes to do integration. And it was really good to see the real examples from facilities. One of the key reflections from me is really integration is very dependent on the existing facility requirements, the client type that they see. And you might not have a one case fits all scenarios. What is really important is to understand the context of what you're working with. What remains the cornerstone for this conversation is really having an improved patient experience when they come to facilities. At national level, you might have 100 programs, but at facility delivery, it's just one client who is getting all those services. And therefore, one of my takeaways is how do we simplify our client pathways so that they are not burdensome, they are not wasteful, and they are not exhausting to the client. Simplified treatment protocols. I think we've been challenged around having 20 guidelines, and these are just, or SOPs. This is just HIV. Add on the layers of what it takes for all the diseases or all the programs that we do in the country. The PHC ambition is very promissory, but it comes with a greater action to the country. For many years, the ambition for universal care has been a dream for the country. We are at the face of pivoting that forward, but that will call for a lot of government resource mobilization. We are aware that donor funding is dwindling. It's not a new thing. I know the stop work order was the height of it all, but it's something that over the past 10 years, we've seen that trend come through. So as we think around primary health care, what are the facilitators that we need to do to bring the other sectors of health up? A lot of things have been done in comparison to what has been donor funded, but we are not asking ourselves, what are the challenges, for example, that is we're making NCD not work. It's making your general outpatient not work. Those are the areas we need to really put a strong focus on. We've talked about HRH, we've talked about laboratory capacity, we've talked about commodities. All the 6 building blocks need to work optimally if we are to achieve the PHC ambition. Thank you.
Thank you very much, Dr. Obare. I think you're emphasizing that integration depends on the context and should also depend on the specific populations that we are serving. And we should work towards improving patient experiences and ensuring that the patient flows are simplified so that it's easy for them to access services. I think you're posing a challenge to us, to all of us, to think about what are those facilitators that are there within the primary healthcare platforms and systems that the country is working towards that will help us improve other services to come up to the level where HIV services have been before. Dr. Katana, I would like you to chime into this conversation. You've also been within this space for some years now. What are your thoughts with regards to what we should do moving forward? Dr. Obare has touched a bit on primary healthcare and considerations of the facilitators that will enable us improve other services to reach where we have been with HIV as we work towards maintaining HIV services as well. So what are some of your thoughts with regards to how we should move forward?
Yeah, thanks, Ruth, and good morning, everyone. I think this has been a really challenging week and coming at a very opportune time when you are really trying to look at the pivot into the future. As you've said, through the conference, there was a place for the vertical program, there was a place for the speed, and that, has very pretty much been achieved. We are now, pivoting towards endurance, the long term. So the first thing, we need is to distill from this conference. So what does this mean for us as people who are interested in seeing this program not just succeed now, but remain resilient and sustain the very good gains? So one of the things that is always a challenge is when you look at the things against versus the things for at a time of change, it's really just that, temptation to wait for a perfect moment, and I don't think at this point perfection is our desired goal. So I would go with what Nike says. I'm a marathoner, so I reflect a lot around runs. And they say, just do it. But of course, not irresponsibly. They don't just mean wake up and run 42K. They do, they say start where you are, but start now. And I think that's what I would think we should do. Just looking at the reflections, I think we've had quite a number of things. So one, that there are success stories. There are things that are working at the facility. There are things that are working at the county. And there is already the framework that has been provided by the national government. So hopefully, in the next week or two, we are going to have some clarity in terms of what, needs to be done to align, with this and move the country forward. But waiting for a perfect moment is not going to be on our side. The other thing that has been very clear, and I hope we all had the same thing, is the government, continues to lead, but they run with people. And I think just listening to the, the potential, just looking at the presentations, the breakout sessions, the posters, there is a lot of capacity. So with government stewardship and bringing all the key stakeholders on board, and especially the communities to really look at what would be the best fit is something that will be. So I think one, next step would really be looking at, how do we move from this? Because, they say insights without action is just noise. So I hope this won't turn out to be just noise that we made this week, but really, engaging people on that. A key thing that came up is the need for capacity building of workforce in terms of the multiple skills that are needed. I think the baseline is very clear. We didn't go to school to study HIV, we didn't go to school to study TB, we didn't go to school to study malaria, but we really have the foundation. So it's really looking at what are those things that we can do to sharpen the skills so that any health worker who comes across the patients because they don't experience this, their health in silos, that they are able to provide that comprehensive care. And finally, at the planning level, and I say this timely because we're just working on this G2G arrangement around the health cooperation framework. I think this is an opportune moment to really look at how we can support the government's vision and the government agenda to really align the resources, to align the systems, and to align service delivery so that we move once and move forward all together. Otherwise, thank you very much. We really appreciate, but most importantly, just to say that this integration conversation is really about a change in mindset. We will only succeed if we are able to pivot, from programs to people, from outputs to outcomes, and really from the short-term gains to the long-term. And integration itself by itself is not a dilution, it's actually a strategy. So we all need to embrace it and move forward together. Thank you.
Thank you very much, Dr. Katana. You highlight that there are actually success stories, and from this summit, we need to see how to distill what we have learned and just do it moving forward. Thank you. I think I have picked something there that maybe our government colleagues will be able to address. How do we move forward? So from this summit, in terms of guidance to the different actors and stakeholders, how do we move forward in terms of stakeholder engagement? Maybe the government colleagues will respond to that as we continue the conversation. Over to you, Dr. Ashia.
Thank you. And just picking up from there, I heard Dr. Katana mention the role of bringing in all the players up to the community level. And yesterday, Mr. Nelson, leading the community session, it was again emphasized that the community play a big role in this integration. At the same time, there are a number of challenges, and the response to especially ensuring that we achieve health without barriers needs to involve more than what you've just had in this meeting. Mama Rosa said she would wish to continue getting services, and her team, from the diocese. At the same time, we have one of Mama Rosa's clients who is having hypertension and needs to go to the facility and get the hypertension care. And as part and parcel of PHC, if they're pregnant, they need to go to the MNCH. While we are also looking at issues of funding, we don't have enough funds to be able to spread to all, and that is why some of the dioceses were closing. What insights do you have for these to the communities on what is going to change, learning from this summit,
as we ensure that all the communities are involved as we want to achieve health without barriers for holistic HIV response.
Thank you very much. Before I came to sit here, Professor Ndwati reminded us that when we talk about integrating HIV into routine healthcare, we are going back to where we came from. So it is not new. So two imperatives probably got us out of where we were because HIV was a public health. The numbers rose very rapidly and the money came in. Yeah, the numbers are still high, but the money is now not there. Although for me, I would not say that we integrate simply because there's no money. I think it is one of the options to look at, one of the best strategies to put in place, even where you had money. But why I'm emphasizing that point, you know, we can sit here and say we are rooting for integrated, people-centered health services. But we look through the door. If somebody can step in with the money, then we go back to where we were. I don't think that's the best way to be. If we want to model care to make sure that people get services, and we say integration and DSD are strategies to use, with or without that money, I think we should stay that course. And therefore, I want to say that for communities, if you want to test for HIV and know your status, go to a facility near you or to a place that you like to go into. And if you test positive, please desire that you are on treatment and get that treatment where it is, regardless of what the name would be. From Monday to yesterday, we have been repeating that for the HIV community of which I come from, the question was never going to be if we integrate. Actually, since 2024, the question of when to integrate was also answered. So what we are dealing with right now is the how. And I want to borrow from Professor Kimaiyo. We can do a head count. If a CCC or a DICE has 6,000, 8,000, 10,000, maybe give it another name, expand its services, and then let it be. I think the issue is that we didn't say close all CCCs because we were going to run very hard to go and protect Kenyatta, the KNH one. What we said is that the auxiliary that probably the numbers were too few and healthcare workers cannot be available, I think could be linked to the wider facility so that care is maintained. I don't think it is wrong if there's a DICE that has the large number of key populations living with HIV and key populations who want to prevent HIV if they expanded services and considered like non-communicable diseases. Yesterday, I keep on reminding us that one of the documents the CS launched here is integrated guidelines for preventing, treating, and managing HIV, STIs, and viral hepatitis. But we keep on stopping at the HIV. So if a DICE has been useful, if a CCC has been useful for STIs and viral hepatitis, and the numbers are there, can't we work with that in an integrated manner? Because what is not tenable and what is not feasible is a CCC that only want to take your blood to test and then put you on ARV and just keep monitoring that you are virtually suppressed. We don't have those healthcare workers. And we go back to stop work order. We have to appreciate counties because one morning they woke up and realized that they have the medicines to give people and they have the people who need that medicine, but they didn't have healthcare workers. What did you expect them to do? But they continued to give people services. In that manner, today we've listened to Casco from Kisumu. In their own assessment, integration has gone to 70%. And it's something that we really appreciate. Actually, some of the recipients of care in Kisumu have not even realized that this is now integration because no significant change has come in. But some really have realized simply because they were in a partner in a container serving 18 people, and those 18 people were advised, please join the rest in another area. And I don't think we need to take offense if we are told that this container with 36 clients or this container with 120 clients, please consider taking your medication out of these 3 options, facilities, you can choose one. I don't think that is an offense. Therefore, for me, integration is the way forward, is the way where we are going. The issue is the how. Now, for recipients of care, I already told them that you should also see it in you, that you want to stand with the care provider and you want to stand with the NASCOP, NDCC, and everybody who provide care. The question always is, what is your contribution? And your contribution need not to be financial. Your contribution is waking up one morning, I'm going to care, and also doing as you are being told. And that's what we call self-care. And your contribution is standing with the NASCOP or the CASCO so that you form a community ARD group, so that you contribute transport to the leader who is going to collect medicine and viral load results. That is what we call self-reliance, because we also have to occupy our space. And we are heavy on HIV. And cancer we have been told here, cancer, this morning we were told that women living with HIV are 6 times more likely to present with cervical cancer than women who are HIV negative. So if the cancer community were in this room, people who have cancer, the conversation is going to be different. But I can assure you that if we continue doing these meetings, including this summit, by 2027 or 2028, you are not going to have a community that we call people living with HIV only joining. But I also want to appreciate that in this meeting, both NSCDC and NASCOP brought communities in. This is the largest number of communities gathering in a single meeting because the numbers are counting to 120. And as we have been here, we are not here just to listen. We are also here to contribute. And that's why we say in partnership. Communities come as partners and they have to contribute. Now, contributing means that there is also a responsibility for you. So what is your contribution? And therefore, for me, as we'll be closing and there is a communique that need to be done, we need to pick that. And the spirit is what we heard from Tharaka Nithi this morning and what we heard from Kisumu. What is going on can be made better. And we can work together to make sure that we get a good service for HIV, TB, and malaria, even with the arrangements that we have, which we call integration. For me, I spelled out 2 areas. Healthcare workers has been repeated here, including lower cadre, mentor mothers, peer educators, adherence counselors. And you heard from Tharaka Nithi, they embraced that community and they're working with them. The second one, please, what is working, upscale it up. This is the time to scale up differentiated service delivery. Give people who are virtually suppressed medicines for relatively longer months as you figure out what is happening in the facility. Scale up community pharmacy models and community RT groups so that we support each other in this journey. And you have a very large cohort of young people who have HIV, and HIV is lifelong. So even after 2030, you will still be talking about how do you sustain people in care. You shall have ended AIDS, but you will have people with HIV. Thank you very much.
Thank you very much, Nelson. Thank you for reminding us that integration does not mean closing CCCs. It means that we contextualize depending on how many patients are there and how many clients are there, as well as what kind of populations are seeking services. And also thank you for reassuring us that our communities of recipients of care are willing and going to take charge of their health services. And that is really the core of self-care. And also that is going to help us to work towards self-reliance when communities can also take charge of their own care. You've also reminded us that we need to scale up what is working, and these things are working within the counties, Waziri, from Kirinyaga County. We have heard today from Tharaka Nithi, we've heard from Kisumu over the course of the several days. We've been hearing what other counties are doing. I would like to know from where you sit also as the deputy of the CEC's caucus, what are the counties going to do differently or better moving forward to support this agenda?
Thank you very much. Ladies and gentlemen, good afternoon. Yeah, I needed to introduce myself because I realized that it has been said that all people have been introduced. I've not introduced myself since I came around. And that is why maybe we are failing to even understand what particular position do I hold, even maybe in healthcare. I mean, the CC's caucus. I'm the Secretary General for the CC caucus. I'm not the deputy. That is number one. And I'm also the CC member for medical services, public health and sanitation in Kirinyaga County. One thing that is very key and very important for me to state this particular hour is that though we are going the way of integration, it has been, a big advantage and a big achievement by way of the programs that we have been having those over 20 years. We cannot just, put it off that they have not done, quite a good job. We have come a long way, and therefore, Dr. Mulwa and the team from NASCOP and all the partners, I wish to take this opportunity to thank you and to say congratulations because of the work well done. Otherwise, if it was not for that kind of program, it would have been difficult for us, even as a country, to achieve what we have achieved today. In fact, many years back, when I started working in the Ministry of Health, say 1992, those years, the HIV prevalence was quite high, even in my own Kirinyaga County. But today I appreciate, all those particular partners who have injected their investments in the control, prevention, and even the treatment of HIV, that as we speak today, for example, Kirinyaga County, we are at 1.7% prevalence, meaning that there's a lot of work that has been done, and it is really appreciable. So, number two, I would like to state that it's only fair when I'm here as a CEC, and it's unfortunate that we do not have quite a number. We were here with only Dr. Ganda, who is our chairman of the caucus. I don't know whether we have any other who came later, and if there is, it's important for us to recognize them. But at this level, I wish to state that this information for me, as others have said about integration, is a question of taking action now, so that we go down and start it off if we have not started. But I want to believe quite a number of counties have started this particular process of integration. And I think in our circles as CC members, we are the people who are supposed to take lead. And therefore, if there's no leadership in these programs or in this particular business that we are doing in health facilities or in our counties, really, we may not see, the light at the end of the day. So therefore, for me, I think for us at the leadership level is that we need to take action, especially during, at that level of the county, whereby we must have to consider other partners. Other partners how? For example, if we talk about the county assemblies, they are quite important for us, because you must have to fight for your space in terms of the provision of the budgets. HRH, as you're aware, that the partners, the donors are leaving, it means that we are having a bunch of people who have been supporting us in terms of implementation, in terms of taking care of our HIV space. And therefore, we must need to recognize them, because if they left the space, then we shall be having a very deep, kind of a pocket whereby we are not able to meet the requirements that are expected. So therefore, I implore the leadership of the counties, and especially the CC members, to have some sitting and discussions with, county assemblies, committees for health, so that they support. I want to believe that you saw the presentation from Kirinyaga County, that is on Monday, that we have been able to come to a level whereby we are in a position to buy, the opportunistic infection, drugs for our HIV patients from our own particular budget. We have been able to buy certain, commodities from the same budget, that is about the laboratory testing and etc. And therefore, in this coming few months, we are sitting down again. We have already taken that initiative, with the Public Service Board in Kirinyaga County. Why? To make them understand the need to absorb these particular healthcare workers who have been taking this place in the implementation of, prevention and the treatment of HIV from our partners, so that we don't lose. So that is number one, that I may want to send, that information to my colleagues and the leaders of the counties. Number two, we need a proper involvement, as it has been put by others, from the national government, together with the county government and other, stakeholders, that we may have a sitting, we may have agreements as we move forward, so that we can do this. But really, let us not make it so difficult that, integration is a big issue. It may not be a very big issue if you have the will to do it. And therefore, it has been put by others that we are not going to state again, we are meeting to discuss integration. It should start, and every person should start it from one step going forward. And I want to believe that nothing starts from above there. We must have to start from somewhere, and then we walk, even if we do not walk together, but we are moving in the same direction so that we can achieve this. So therefore, an example again of Kirinyaga County, we have been able to do 78 health facilities out of, 76 out of 78 facilities. We have been able to deal with integration, outpatient and also outpatient and also MCH, so that every other facility is doing this. What are we supposed to be doing, really? Capacity building for our healthcare workers is very key and very important, so that everybody will embrace this. I had another question as I finish, asking about, issues to do with primary healthcare. Issues to do with the prevention. Has it been taken care of? I think that it is key for us to understand that with the primary health care, and I'm happy that SHA is represented here, we have been at that particular level of COG, been able to identify certain particular activities that are going to be done in terms of prevention of, diseases and infections in our communities. And that, of course, will also involve HIV prevention and control. Some of the activities that need to be reimbursed from that particular community level. That is where we have the community health workers, where we have the public health officers, and where we have the SHAs who have been involved in this, so that we can have some kind of reimbursement through the primary health care fund. So therefore, I think for me is to state and request even the national government in terms of the allocations and such, that we are in a position to implement what we expect them to implement in terms of integration. Otherwise, thank you very much.
Thank you so much, our CC. And you've just reminded us that it's time to take action. If you've not taken, you are being left behind. And on this, it's not a big issue. Integration is not a big issue, as long as the will is there. You've also been able to remind us that leadership is key, and it has to be at all levels for this integration to succeed. And as counties, we need to fight for our space. We need to have that share of the cake. Work and have meetings collaboratively with the county assemblies. Be able to make them understand why you need to be part and parcel of that big cake and not to be taken as a small one because the donors are still there. The other thing that you've brought to the front is working closely with the national government. That is very important, and leveraging on opportunities like SHA, which is also very important. Thank you so much for that. Dr. Murugu, all the way from Sunday, there are a lot of insights that have been shared. As NSDCC, working closely with the communities at all levels, from national multi-stakeholder partners, with the communities of schools, and the communities themselves, the members, the recipients of care.
What is your take home? What is your way forward, given the call for having health without barriers?
Thank you, Dr. And thank you for the question. What is clear is that we are in the midst of integration. I think everybody has said that we are not preparing, we are not anticipating, we are not discussing some theoretical bit of integration, I think, which we have been doing for the last few years. We are right in the middle of it. And it is very uncomfortable for most people to build a plane as you fly it, but it's the position we find ourselves in. But there is a lot of light at the end of the tunnel. As you say, Dr. from Kirinyaga, it's not that big a deal. Dr. Katana, you said, don't wait for perfection. I would say, build on what you already have. There is a lot of experience from the counties and from the implementing partners on what we have done with integration. We might not have called it that. We might not have had a standardized way of defining integration, but we have it. And I want to also dispel that misconception that we don't have any policy documents that guide us on integration. We do. The country launched an integration framework last year in December that is currently being worked on by all the 47 counties to give us operational plans. Does the framework define integration? Yes. Does it tell us how to do it? No. So that's the work that is ahead of us. I'm reflecting on the way we are defining integration. In itself, that is a bit siloed. We have to come up with a common understanding, a common script, common indices of what integration is. What are we going to be looking at as a country? What are we going to be measuring? How will we know we have become integrated? We need to work on how to actualize the great ideas that have come from meetings such as this ones. How do we operationalize integration so that it makes sense for our context, so that it delivers and answers the hard questions? And some of the hard questions are, what is it exactly you're trying to solve with integration? What are you trying to mitigate against? What is this that you're trying to either optimize or avoid? We have to answer that. I think in many ways limited ourselves to thinking around finances, that now we don't have the money, therefore we must integrate. Let's be also honest with ourselves and say that there are bits of our system and our response that weren't working, right? We still hadn't gotten to the 95, 95, 95. We had not optimized health as our constitutional right. So there's an opportunity here to not only get sustainable, to get resilient, to get adaptable, all those lovely words, but also to optimize our health systems for better health for all. The issue of prevention, I think, is also been, and prevention not just around HIV, but looking at prevention a bit more holistically. Because a lot of the diseases share behavioral, physical, economic risks and drivers. And therefore, when we start looking at prevention and we're still thinking about it in this disease siloed way, where we're only talking about HIV prevention, I think we miss the goal. As we integrate and as we define integration going forward, and we do that not just for care and treatment, but also for prevention, because the drivers, the patient is the same, and what makes them vulnerable to one makes them vulnerable to another, and therefore let's be a bit more efficient even with that. Thank you.
Thank you very much, Dr. Muluki. I think you are reminding us and emphasizing that we are in the middle of integration and we need to continue building on what it is that we have. You are telling those of us that do not know that there's an integration framework that actually exists. And what we need to work on moving forward is to define what exactly we are measuring, what it is that we're trying to optimize, and what it is that we're mitigating against, even as we use this as an opportunity to optimize our health systems. Dr. Newton, we would like to know from NASCOP, that is the technical lead for HIV, STIs, and hepatitis. What should we expect moving forward with regards to integration? What guidance are we giving the counties? What guidance are we giving the facilities? What should we do when we live here? The panelists have told us that integration is not complicated. We should build on what we have. We should just do it. What should we do when we leave Mombasa, Dr. Newton?
Okay, thank you, and thank you for giving me this opportunity. I'm looking at my government colleagues, CEC Kirinyaga, and I look at Dr. Murugi here from NSDCC. I think I want to emphasize what the CEC Kirinyaga said, the importance of partnerships. We are not saying that we no longer need the partners to be in our midst. We are saying that it is because the progress we've made is because of the strong partnerships and running the prior programs. The graphs have come down substantially, and the only way forward now to sustain the gains is to integrate. But then we are saying that instead of having partner-led programs that may be parallel, that may be duplicative, that may be, competing sometimes with each other, and, just inefficiently running with the government in tandem, we are saying that the future of integration should be government-led. The government must take the lead, both in terms of just giving the plan. We are looking at one government plan, and everybody feeds to the plan. Yeah, so it's very imperative that the programs that were initially heavily donor funded, that is HIV, TB, malaria, MNCH, vaccines and immunization, all those programs must look at how they can come together, integrate, and the government takes the driver's seat. Not to say that there are no partners. The partners will always be there. There are places where the government cannot reach. Yeah, there are places where the government cannot reach, and we know the partners and NGOs do a lot. But then just looking at, for government to lead, then the government has committed, and you've seen from the presentations here, that the government has committed to enhance its domestic resource mobilization. Just looking at the audience here, domestic resource mobilization does not mean that the government only must allocate. The government is the leader. We have the private sector, the FBO sector, the NGO sector. We have so many ways we can actually mobilize domestic resources. So if you look at mobilizing domestic resources as just government allocating budgets, then that is not innovative. We talk about innovative financing mechanism. Traditionally, people have talked about sin taxes and stuff like that. The other day, we saw the president launch the National Infrastructure Fund. And I think in the infrastructure fund already we have about 400 million, was it 400 million Kenya shillings or 4 billion? I think 4 billion Kenya shillings from the IPO that came out from Kenya Pipeline. So if you guys didn't know, we have infrastructure fund for HIV, which is says that the government should allocate around 0.05% to 1% of their infrastructure budgets to HIV control. If we just took let's say just say 0.05% of the 4 billion that is already in the National Infrastructure Fund, then we already have some money to start. Yeah. So we are looking at the government, and when I talk about the government, I talk about the national government and the county governments allocating resources towards integrating and just ensuring that we reach the end goals. So if you look at what we can do if we actualize our HIV infrastructure fund, there's a lot we can do. The other day we were having a chit chat with some of my colleagues. We were saying that if the government can just buy first lines, progressively by 2030, we buy 100% for first lines, especially for the first line ARVs, first line TBs, first line malaria, then we will be at a space. When I look at my county government colleagues, I think the lowest hanging fruit right now is to ensure that the HRH is integrated. Yeah, it was very difficult to sometimes when in the integrated space to have different cadres of HRH that is unintegrated and is partner-led, and there's a lot of competition. So that is what I would say that. Then the last thing I would talk about is just the role of the policymakers. When we sit here, I know that the communities are looking at us, the partners are looking at us, the private sector is looking at us. They're looking at us, challenging us to integrate first. So one of the things, and there's going to be a joint communique from this, is to say that the government is also looking for ways to have integrated platforms for delivery of health services. If you are not aware, we have a health policy platform that brings together all the partners, all the development partners, and all the implementing partners, so that we actually have one platform. We move towards one outcome, and we move towards the universal healthcare and sustainability goals. So I think I'll stop there for now, but I just want to thank my panelist colleagues here for their input to the session. Thank you.
Thank you so much. Thank you so much, Dr. Newton. Just reminded us collaboration is the way to go. And at all levels, at government, at county levels, there is what it takes to be able to complete this journey, because it's what is already started. And we look forward, under the leadership of the national government and NASCOP, to see this reach its fruitfulness. So with that, we'd like to come to a close, and we can all see that integration is underway. It's not anything new. All that is needed is more boldness, more alignment, and more sustained commitment for us to achieve our goal and have health without barriers. As I say, thank you to our fireside panelists. I would like just to call them front. We take a photo, and I don't think we'll have a session for questions. These was just insights from the team. Thank you so much.
I think that clap was a bit weak. Can we applaud the team, please? Thank you. We are bringing all this to a close, but before we do, I'll call upon Christabel Awor. Kindly, team, project us her bio. Yes, so Christabel is coming to make a presentation on collaborating for quality, ensuring safe HIV self-test kits. I'm not able to read from that far. Anyway, she's a medical lab specialist with extensive experience as is projected, so I'll give it over to her.
Okay, thank you so much, Dr. Nelly. Good afternoon, everyone. I think they saved the best for last. I'm Christabel. I work at NASCOP as a senior laboratory analyst, and I'm going to take you through a presentation on collaborating for quality of HIV tests. So there are a number of players in that field. And I believe that by collaborating, we can bring the best outcomes, even as we look forward to integration. So in the lab, we normally talk of good quality tests. So I'm going to be sensitive to the changing priorities, and I'll also stick to the specifics. So I'll keep it short, just a few minutes of your attention. You can roll it. Okay, so even as we look forward to integration, quality is also important. And HIV testing is a gateway to HIV prevention and treatment. So we've also talked of other things when it comes to prevention. And I believe that HIV self-tests have a special place when it comes to integration. It expands access to HIV testing. We still have populations that are still not accessing HIV testing. So HIV testing, self-testing can help us to fill that gap. It's recommended as a complementary strategy for HIV testing. So it's not coming in to replace the algorithm that we use. It's coming in to complement. Can go to the next. So HIV self-testing will help, is important for integration, as it will help expand HIV testing services beyond the facilities. When HIV testing started, it was in the lab, it moved to the HTS providers, and now we have the self-tests. So again, it's moving outside the facilities, and it will help reach the hard-to-reach populations and enable early linkage to treatment for those who are positive. Because again, with a reactive test, the clients are expected to come to the facility for confirmatory testing. So even as we look forward to having more kits in the market for HIV self-test, quality assurance is still key across all the pathways, right from procurement up to the end user. We can go to the next slide. So just a few things when it comes to quality issues, when it comes to HIV testing. There's a study that was done in Kenya, and it was on mystery shoppers in Kenya pharmacies, and it highlighted a number of issues when it comes to quality. There was also an article where an agency warned of faulty test kits in the country. Again, there was a time when some kits were recalled from the Kenyan market because they had been falsified. So, so as I mentioned earlier, there are a number of players when it comes to quality assurance. We have the regulators, we have the labs, we have the procurement agencies, we have issues to do with the training, competency, recording, and also post-market surveillance. So we have many stakeholders in the field, and each one of us, for us to achieve quality, we are expected to play our role. So I'm going to focus mainly on regulatory approval as I look at some of the work that we've done as the HIV program to ensure that we have quality kits in the market. So as NASCOP, we are entrusted with the technical guidance, and before kits are accepted in country, so after WHO pre-qualification, we're also supposed to do our due diligence as a country and ensure that the kits that are in the market are of good quality. So there's a test kit that we call Confisign HIV self-test kit that has been evaluated in the country. This will be the second one in the market, a blood-based test. So we started with the oral-based HIV self-test. There's another blood-based HIV self-test in the market, and now this is another one that the program has been able to evaluate.
So this is the format of the kit. It's a vertical flow rapid test format. I'm sure most of us are used to the lateral one. And the way it's packaged, it's one test in a pouch. And another unique thing about this kit is that there's direct capillary blood collection. So you don't need a capillary to collect blood. You just use the test device. You don't need any other equipment other than the strip. And then it also has a biological control line, meaning it can test the human IgG. So only the human sample can work in this. So the study objectives was to evaluate the diagnostic performance of the Confisign HIV self-test kit. And we also went further to check the usability and the acceptability among the intended users. So you'll find that most studies only concentrate on the diagnostic performance, but it's also good to get information from the end users on how acceptable the kit is. So this study employed a cross-sectional method. It was conducted between September 2025 and ended in January 2026. It was conducted in 4 counties, the counties of Kisumu, Siaya, Nairobi, Machakos, and we used the HIV testing algorithm in the country to get our reference results. And those are the results that were used to manage the clients. And then usability was assessed through observation and use of questionnaires. So there's a report with all the details on the study. So we managed to enroll 1,507 participants, of which 70.6% were female, and the median age was 29. The largest age group was 24 to 34 years. These are the results. So we looked at the clinical performance. The sensitivity was 100%, specificity 99.9%. The PPV was 99.8, the NPV was 100%, and the kappa was 0.998. On usability, it had very good ratings. 99.6% of the users read the instructions for use before doing the test. 94% of them found the instructions easy to understand. 97.7% were confident performing the test, and 91% preferred testing at home or in mixed settings. There are also challenges with finger pricking, which is something that cuts across. So when we looked at our findings, they were similar to what was done in Uganda, what was found in Uganda. Again, for the Uganda study, they had a sensitivity of 100%, specificity of 99%. So in conclusion, this kit demonstrated excellent diagnostic accuracy, and there was near perfect agreement with the national HIV testing algorithm, and it was also highly acceptable among the end users. So the accuracy and reliability was high, more than 99%. It was user-friendly, and it has got potential for integration. So this work was done by a number of us. So led by the Ministry of Health, so that was NASCOP and National HIV Reference Lab. We got ethical approval from KNH-UON, Ethical Review Committee. We also worked in collaboration with the county governments of Siaya, Kisumu, Machakos, and Nairobi, and also got technical support from Jane Body. So a number of considerations, even as we look at quality assurance of HIV test kits, we need standardized, we need shared standards and protocols when it comes to quality. We need to adopt a uniform QA guideline across institutions. Sometimes you find a lot of challenges even in the development of the protocol because there's no standardization. Open communication, so different players are in the field, but we need to know what each other is doing. Joint monitoring and evaluation, capacity building and training. So we need to leverage on expertise across institution as we train staff, and also innovation and problem solving together. So working collectively to address the challenges that come up. Thank you very much.
Thank you, Christabel, for that presentation. Up next, we are going to make declarations and commitments, and we'll have representatives of the whole group. So we'll start with the adolescents and young persons. So I'd like to call Marianne Chebet and Brenda Oyiko. Kindly clap for them as they come up. And immediately after them, we'll have Dr. Newton O'Malley as well.
Hi everyone. Good afternoon, everyone. So my name is Brenda Owiko, and I'm a young person. So for the past 4 days, we've been here at the Health Integration Summit. A lot has been said, a lot has been done. So we are here to just give you some commitments for you to commit for us, our wants and our needs as young people. So with all due respect, I would like everyone to stand up. So as I read the whatever our needs, I want after every need I read, you say I commit, raising your right hand, saying I commit. Let's rehearse. I commit. Say it passionately with a smiling face, because we will hold you accountable for this. Okay? So we go, I commit. And you're not smiling. I'm not seeing smiling faces. Okay, so we go. Do you commit to strengthening an integrated, coordinated, youth-responsive health system that delivers comprehensive services for adolescents and young people, including HIV prevention and treatment, sexual and reproductive health, mental health services, gender-based violence response, and social protection? I'm not seeing your right hands passionately saying that you commit. I'll repeat, and I want you to I want smiling faces, okay? So do you commit to strengthening an integrated, coordinated, youth-responsive health system that delivers comprehensive services for adolescents and young people, including HIV prevention and treatment, sexual and reproductive health, mental health services, gender-based violence response, and social protection? Thank you. You're doing well. So on the second one, do you commit to intensifying coordinated national and county efforts to address the triple threat of new HIV infections, adolescent pregnancies, and sexual gender-based violence, with a particular focus on the needs of adolescent girls and young women and other vulnerable young populations? Thank you, you're doing very well.
Good afternoon, everyone. My name is Marianne Chebet, and I'm glad to stand here on behalf of young people. We're going to do just as she was saying. I'm going to continue reading the commitment. And she said, you raise up your right hand after I've read the commitment, and you say, I commit. Are we ready? Yeah, we can go on. Do you commit to expanding equitable access to HIV prevention services, including pre-exposure prophylaxis, by strengthening youth-friendly services, community-based delivery models, peer-led demand creation, and digital health platforms that reach adolescents and young people where they are? Do you commit? Good. Do you commit to ensuring adolescents and young people are meaningfully engaged as partners in health governance, including policy development, program design, implementation, monitoring, and accountability at both national and county levels? Good. On the last one, do you commit to advancing evidence-based prevention approaches, including comprehensive sexuality education, life skills development, county engagement, and youth-led innovation to empower adolescents and young people with the knowledge, skills, and urgency to protect their health and well-being? Do you commit? Last but not least, we will hold all of you accountable, and we will not relent. Okay? Do you commit once more? I commit. Thank you.
And actually, remember, there's nothing for us without us. That's why we are here. Do you commit? Thank you.
Okay. Let me just- Thank you for the youth. We commit. Yeah, thank you. So, thank you for staying up to this time. At this point, I have the pleasure to read you the joint communique for the Health Integration Summit 2026 on behalf of head NASCOP. After I read this communique, then we will have the representatives sign. And I hope the table is set for signing so that all the representatives sign this joint communique. So this is a collective commitment to sustainable health integration transformation. And on this 19th day of March 2026, at the Health Integration Summit held in Mombasa, Kenya, we, representatives of the government of Kenya, including the Ministry of Health, the county governments, the National AIDS and STI Control Program, NASCOP, the National Syndemic Disease Control Council, NSDCC, development partners, communities in all their diversity, implementing partners, and the private sector, acknowledge that an estimated 1.3 million people are living with HIV in Kenya, with a national prevalence of approximately 3.0, alongside continued new infections and AIDS-related deaths. That Kenya has made significant progress in its HIV response and broader health system strengthening efforts, that ongoing health reforms, including the Digital Health Act, Social Health Insurance Act, the Primary Care Act, provide a strong foundation for integrated people-centered service delivery, that integration is essential to sustain gains in HIV and advancing UHC and the bottom-up economic transformation agenda. We recognize that health integration is a strategic imperative for building resilient, efficient, and equitable health systems, that communities and counties are central drivers and pesetters of integrated service delivery. We express concern that the global health financing landscape is rapidly changing, with a shift from donor dependency to domestically financed country-led responses, that health systems face pressures, including resource constraints, workforce challenges, and the need for interoperable digital and diagnostic systems. We admit that this is a critical and opportune moment to accelerate the integration process across programs, levels of care, and health system functions in order to sustain impact and improve outcomes. Energized by the collective commitment of the national and county leadership, communities and partners to deliver people-centered, rights-based, and quality integrated health services. Now, therefore, we hereby commit to 1, strengthen integrated service delivery, collaborate to develop and implement context-specific, epidemiologically relevant integration models anchored in primary healthcare, while safeguarding program quality and outcomes. institutional system transformation agenda. So this communique will be signed by one community representative, and they can come to the podium, the community representative, Nelson Otwoma, or his representative. The county representative, and I'll call upon the CECM caucus representative to come for the signing. Private sector representative, Nelly, who is the private sector representative? And so I'm waiting for the CECM, County Executive Committee member representative, CECM Kirinyaga, right? What is this? And okay, so I have the names now. CECM Kirinyaga. Oh, he left. CDH Kericho, Dr. Betty, my friend. Then representative from CHAC for private sector representative. Nelson, now you have company. Yeah? And Dr. Mulwa for Ministry of Health.
commit.
Nabeba juu wote mkisimama nikipigwa picha. Yes, yes, sir. Get you another mic. Okay,
So I feel like the Chief Justice declaring the winner of the presidential election. Yeah. Okay, so once all have signed, I will request this the representatives to stand up, hold their copy, and each of them say, "I commit" in unison.
I commit. I commit.
I commit. In unison.
In unison means what?
Warudie. Okay. I commit.
I commit.
Thank you very much.
Hii copy nakaa naye.
Oh, you.
I don't know. So you can exchange ones and you go with one.
We commit.
Sign all of them. Later. Yeah. You sign all of them, and then you give them a copy which is officially signed. Which we are okay. Official. Official. Okay. So Doc will give you a copy. Okay. Thank you. Thank you. Thank you, Doc. We can give them a good clap as they sit. So Kayamba Africa, we can have a celebration for the signing of the declaration.
Ladies and gentlemen, one of the most difficult things is to perform to some people or many people whose minds are already at home. So I want to take you home. I want to take you home. I don't want to send you home. I want to take you. I want to ask a random question. How many used Nyayo bus? Nyayo bus, ile ya green. How many were given a chance to join the mass choir? Hao ndio wasimame. If you were in the mass choir, simameni. Please, mass choir ni ile mulikuwa mnachukuliwa na Nyayo bus, munapelekwa practice, munaenda kuimbia president Nyayo Stadium.
Wala.
Alafu munafanya nini? Munapewa free shoes. Unakumbuka? Free shoes, socks ya white. Wewe ulikuwa unalipwa? No, you are very lucky. Na bendera. Aya, wale wengine atusemi hamukusoma, lakini simameni tu. Tafadhali simama tu. I want to show you how we used to do it. By the way, niko na mwalimu mwenzangu hapa. We were teaching kids, primary school kids that time. Wale hawajasimama, baraka zenu zinapita kwa hewa. Bas. Simama. I want us to go home, but we want to go nicely. This is what the first instructions were given for the mass choir. You start with one, okay, usually the right one. But if you are a lefty, left. Aya, right leg, unatoa nyuma, mbele. Unatoa nyuma, mbele. Unatoa nyuma. So far, so good. Clap for yourself. By the way, teaching more than 300 kids to do one step forward, you would sweat. Second, the song. So we start with the movement, then the song. Ready? 1 and 1. Answer. Sisi wanawanyayo tunaingia. Sisi wanawanyayo tunaingia. Nyayo, Nyayo tunaingia. Nyayo, Nyayo tunaingia. Si na wale watoto wanawanyayo tunaingia. Sisi wanawanyayo tunaingia. Si wasikii Nyayo tunaingia. Kwa masa anasema shout, shout. Peperusha bendera. Sisi wana bendera, bendera tunaingia. Haya, wapi bendera ya Kenya? Peperusha bendera. Nyayo, Nyayo tunaingia. Na Nyayo tunaingia. Haya, stand at attention. We commit. Mtukufu Rais, hii ndio kwaya ya watoto kutoka mkoa wetu wote wa Machakos. Wamefanya mazoezi na watakuimbia wimbo moja. Na kuna wengine walikuwa kimbele mbele, tukiruka hivi au walikuwa wanafanyia mui. Are we ready kwaya? Twende. Remember there? Remember? Na mnajibu kama kwaya. Kila mtu si tushangilie Kenya. Wale huko hawatusikii, hatusikii. Kenya tunayo. Huko twende. Kenya yetu tunayoipenda. Tujivunia sana tukijiita wa Kenya. Kenya yetu nzuri. Kila mtu tunajivunia Kenya, tukijiita wa Kenya, nchi yenye baraka. Nchi yenye baraka. Makao yetu ni nchi ya usalama, kamwe hatutaiacha. Kenya makao yetu ni nchi ya usalama, kamwe hatutaiacha. Kila mtu hatutaiacha. Kila mtu anayependa Kenya ni yule mwenye kutenda haki kwa watu wote. Anayependa Kenya ni yule mwenye kutenda haki kwa watu wote. Haki kwa watu wote. Ukipenda Kenya, hiyo ya pili unakata, ya kwanza unavuta, hii unavuta. Ukipenda Kenya, ujitenge na mambo yenye kuvunja, hiyo unakata. Hatutaki matata Kenya. Hatutaki matata Kenya. Wapi vigelegele ya mkutano wewe? Hey! Are you ready? Are you ready? Sasa tunaenda hivi. Kenya kipenzi chetu, hatutai na milele. Kenya kipenzi chetu, hatutaiacha. Kenya kipenzi chetu, nchi yenye upendo, hatutaiacha daima na milele. Kenya kipenzi chetu, hatutaiacha milele na milele. Kenya yetu, Kenya kipenzi chetu, hatutaiacha milele na milele. Tena ni baba yangu, hatutaiacha daima. Tunaimba pamoja. Kenya, Kenya kipenzi chetu, hatutaiacha milele na milele. Kenya yetu, Kenya kipenzi chetu, hatutaiacha milele na milele. Wote wananchi wa Kenya kutumikia Kenya. Haya, songa mbele baba. Kenya kipenzi chetu, hapo hatutaiacha milele na milele. Kenya yetu, Kenya kipenzi chetu, nawe hatutaiacha milele na milele. Haya, kila mtu sasa tunafanya marching. Mimi ni mwana Kenya daima, ng'ambo nitarudi. Mimi ni mwana Kenya daima, ng'ambo nitarudi. Mimi ni mwana Kenya daima, kondoroswa na wabaya. Mimi ni mwana Kenya daima, nitalenga Kenya. Haya, piga saluti. Mimi ni mwana Kenya daima. Alafu tukitoka stage tunatoka namna gani? Tunatoka hivi. Aho. Aho. Tikisha madogo. Mwana wa mama. Mwana wa mama. Mwana wa mama. Mwana wa mama.
So thank you, Kayamba Africa. It seems we are not ready to leave today. From the mood, Dr. Mulwa, we ought to have increased the number of days up to Friday. But we have to come to the end of our today's session with awards. So thank you so much, Dr. Nelly, who was the chair of the previous session. And mine is simple. I'll be requesting the MOH leadership and, of course, the community reps just to step forward. So Dr. Mulwa, our TB program manager, Dr. Nazila, please, I ask us to just step forward. It will be very important at this moment. Yeah, so we want to appreciate us for being so patient for the last 4 days. And we thank God for his mercies that has enabled us to finish well without any other worry. So as we wait for the leadership to settle, we have a list of categories that the organizing committee, through the guidance of MOH, so I stand guided. The beauty is that when you see Nelly coming, those are the clear instructions. So Davis and Menja, please, you can come forward. Dr. Amenya, oh, okay, please, from UNAIDS. I tell you how sweet it is to always be guided. So as we start, I mentioned that the MOH leadership will be giving some awards to specific individuals, to organizations, both private and faith-based, some academia, and also to the overall poster presenters and some selected oral presenters too. It is good also to mention that the team appreciates the high-powered leadership from MOH that has been with us, and we are sincerely grateful for the PS who graced this occasion, the DG, Dr. Mulwa, and of course our invited guests from Uganda, among other delegates who were invited. That includes me and you. So the committee again wants to appreciate them in a very special way, and I'll be asking Maureen and Lulu as I read out the first names that the technical committee will be presenting a gift to. So as they come, Dr. Kature, you'll be receiving the gift on behalf of the PS. So just to let you be aware that we have a gift for the PS. Dr. Mulwa, you will be receiving the gift on behalf of the DG. And Dr. Nazila, you will be receiving the present on behalf of Dr. Mulwa. So how they'll make their own arrangements, we don't know, but that is government protocol. And then finally, Cordelia Katurebe, we recognize your presence in this summit, and you'll receive your present from none other than Dr. Caroline Mwangi. So as I call them, please, we can start with our able PS, and in good spirit of partnership, Chai will be presenting the award to the PS. So Davis Karambi, you can look for the award, present it to Dr. Katuri. Thank you. We can do very fast, we give the award. So Doc, you can just step, yes. And I ask us to begin with photos. So for the PS, Davis Karambi will be giving it on behalf of many of us. Thank you so much. Thank you. So Dr. Mulwa, you will receive the award, the present on behalf of our DG, Dr. Patrick Amoth. So the UNH rep, thank you so much. Thank you. So to present the award to Dr. Mulwa, Newton, I know you are seated. I didn't tell you that you'll do this, but I remember the many meetings you are calling him to speak. It has been such a great honor to always have him every Monday and Friday attending the meetings. So Dr. Nazila, on behalf of Dr. Mulwa, please receive the award. We thank you. Please hand it to... We thank you. Thank you so much, Dr. Mulwa, for the able leadership. And finally, in this category, Dr. Cordelia, Dr. Caro will present the award on behalf of the committee for gracing this occasion. So please, we can also take a nice photo. We can give a good clap. Thank you so much. Thank you. So allow me to welcome Dr. Nazila on behalf of the MOH leadership now to do other categories other than the committee. So Doc, category 1 to 6, thank you. And as you are called, please save us on time by just coming here. The certificates are virtual, you'll see them being projected here for you, but later on a copy will be sent to you officially from the head office. Thank you.
Thank you very much. I'll move straight into category 2. We are awarding the national integration partners, our partners who are supporting us in this integration agenda. And I'd like to call upon representative from CHAC.
Agree.
And to award this, I'd like to call upon Chai to please step forward. Okay. I'd also like to call upon AMPA representative to please come on the floor. Thank you. We'll now move to category 3, where we are awarding the National Integration Individual Champions. And I'd like to call Dr. Evelyn Ngugi and Nelson Otuoma. Thank you. We'll now move to category 4, person-centered champion, and I'd like to call Professor Ruth Ndwati. Moving forward, category 5, I'd like to call upon counties for various awards. For VTP, I'd like to call upon Kajiado County. Kajiado? Okay. Next county, Kitui County for TB. Thank you very much. I'd like to call upon Kirinyaga County for NCDs, that is CVD in PHC. Okay, moving forward. Yeah. Moving forward, Kisii County for diabetes control. Finally, in the county categories, Migori County for cervical cancer screening and treatment. Yeah. We can.
So I ask us to step forward for a group photo. The first 6 categories. So after that, I'll ask you to read up to where communities are, then leave the communities for a while, please to read for themselves. Yeah. Thank you so much. We can resume our seat. So I'll ask Dr. Mulwa to come and help us read the categories from 6 all the way to 12. Thank you, to 11. Thank you, Doc.
Thank you very much. Digital health systems. The award goes to Homa Bay County for rolling out facility-wide EMR. We have next category is on health products and technologies. We have 2 counties. Actually, we have 2 counties on the laboratory category, which is Mandera County for reporting and Wajir County for sample networking. So we have Mandera and Wajir counties. Representatives from these counties. Okay, so I'm told they have left for the mosque. So let's applaud them and appreciate them. We have Kirinyaga County for pharmaceutical products. Kirinyaga County, CC was here, Dr. Karoki, but I understand he had an early flight. Then in the same category, we have West Pokot County. West Pokot County. We appreciate them. Category 8, care and treatment. Oh, this is West Pokot. Karibu. Let's applaud them as they come forward. Care and treatment, we have the People's County of Nakuru County. On the work that we have done on integrated screening and management of AHD, Nakuru County. Thank you. Let's appreciate them once more. Next category is on leadership and governance for integrated health services. And this award goes to none other than Kisumu County. Congratulations, Kisumu County. The next category is on healthcare financing, and the award goes to Murang'a County for domestic resource allocation for HIV services. Let's applaud Murang'a. Let's applaud Murang'a. And you can see they have come in good numbers. Thank you. Last and not the least, we have on award on health workforce. And this award goes to the People's County of Kericho County, who have transitioned HRH from donors to county health system. So the county director, Karibu, let's applaud Kericho. Thank you. Thank you. Thank you. Now the next categories will be undertaken by the young people themselves, and I ask Jerop to come and lead us in calling out the awardees from the communities.
Yeah, so thanks, Doc. Before we go to communities, I'll request Dr. Mulwa, Dr. Kithure, and Dr. Nazila that we take a group photo with the leadership of the counties. So please come for a group photo shortly. Let us appreciate the county teams. Thank you, thank you. We can sit. So Dr. Mulwa will be, not yet, Doc, not yet. I want you to still continue standing. Today it will be a bit hot. I'll ask Dr. Mulwa to award the communities.
Thank you so much. I'm not Jerop, I'm D'Souza. Yeah, so this next category is category 12. We are awarding the communities. So leadership and advocacy, this is going to KP Consortium. Thank you so much. Yeah, just stand there. The next category would be AYP championing. This goes to IREP Kenya. For the vulnerable population championing, this will be going to Vulnerable Consortium of Kenya.
Please don't go. Just stand on the side so that we take a group photo. The next category is advocacy and human rights champions, and this goes to Next Gen lawyers. The next category goes to women living with HIV leadership and integration, and it goes to WAFAC. I'll jump over to category 13. leadership and advocacy for inclusiveness goes out to Men with Disability Societies of Kenya. David. I request all of us to come and take a group photo as Dr. David Kimosop takes up the next category. Communities, please come on the stage.
So communities, we can step forward to take a photo. As David comes, okay, the next awards is on the posters. And I'd like to invite Dr. Menya and Angela Langat, who will be able to present the presentations, the gifts. Angela Langat from NSDCC. All right, so the first thematic area, we'll begin with posters, goes to Irene Omwenga from Nyamira County. Angela Langat will issue gifts for the oral presentation. So please be seated. Be seated first. Okay, Dr. Menya, you will present next. Sit down. All right. Nyamira County, they have integrated 90%, 98% of their sites. A big clap for them. Thematic area 2, we have Caroline Wanyama from Ampath. And this is on PrEP Scale Up. Caroline Wanyama from Ampath. A clap for her. Okay, someone from Ampath? Oh. Thematic area 3 is on digital health. We have Kennedy Radieni from Muranga County. Something on machine learning and integrated screening tool. Kennedy Radieni. Thematic area 3, integrated health workforce. We have Davis Bula from Kiambu County. Safeguarding patient confidentiality.
Thematic area 4. This goes to Dr. Winnie Chepkemoi Rotich from Kericho County. Their poster was on using SHA financing for AHD services. Okay, thematic area 6. This is the last poster, thematic area. It goes to Braxidis Maero from Trans Nzoia County, stroke Ampath, on community-based approach services. Thank you. We can now have Dr. Amenya to come in front. We'll want to go to posters. And for posters, thematic area 1. Out of 300 posters, these are the ones who were able to narrow down to doing presentations. And therefore, for thematic area 1, Dr. Sharon Kimani from Nakuru County. Their poster presentation, which made to oral, was on AHD integration in the county. A big clap for Nakuru County. Thank you. Thematic area 2, oral presentation. This goes to Gladys Tuitoek from Baringo County. Hepatitis B rollout within the county. That's what the poster was all about. Thematic area 3 on digital health. This county talked about digital health innovation around Afya Info, and it goes to Kennedy Radenyi from Kiambu County, Muranga County rather, Muranga County. Thematic area 4, this goes to Dr. Cyrus Mugo from University of Nairobi, KNH, on task shifting and psychosocial support services. Okay. Yeah. Thematic area 5. This goes to Dr. Esbon Gakuo from Kirinyaga County on domestic resource mobilization. A big clap for Kirinyaga County. Someone just come? There's someone? Okay. All right. The next thematic area, which is the final one and not least, this goes to Rachel Muema from, their poster was on advancing integrated community empowerment from Trans Nzoia County, I think. Rachel Muema. A big clap for Rachel Muema. Yeah. Thank you very much. We'd now like to invite you for a group photo. A group photo. Yeah, thank you so much. So we are moving to the last one before we hand over to Dr. Grace for the final closure. Allow me to invite Dr. Karen Mburu. In a special way, she will be reading out the names of the technical leads who've worked tirelessly with us to make sure that this occasion, Doc, I request that you move the other side. I realized I might be the only one who can be able to climb through this other side. Thank you, Doc. So she'll read out the names of the leads, and please, as they read out the names, I'll just request us to stand here one after the other so that we take a group photo again after that. Karibu, Doc.
All right, so it's with great pleasure that we now award the Integration Summit Secretariat leads, and we'll first call in Dr. Nelly Pato, and I'm going to request, I'll request Dr. Nazila, please, for the technical committee lead. Thank you so much. Next, I'll call in Dr. Eric Mutua for resource mobilization. Please give him a big hand. Dr. Eric Mutua. Let's give him a hand, please. Okay. Thank you so much. Next, I'll call in Betty Chepkwoni, Logistics. Betty. Thank you. Thank you so much. Next, communication and advocacy, Rhoda Nisa. Yeah. Okay, thank you. Thank you so much. Next, we call in Mr. Victor Kimathi, IT support. Victor, come up. Okay, we'll move on to the next person. I don't see Victor. Rose Angweni, M&E. Let's give her a hand. Thank you so much for your exemplary work as the lead of the Secretariat Committee, Dr. Grace Rabut. Okay, thank you so much. And last but certainly not least, for your overall planning leadership, Dr. Newton Omale. I call them up for a photo.
They come into members can come in for now to join them for a good photo.
All right, thank you. Thank you so much. I'm going to call in the awardees and any other committee member to join us on the podium for a photo.
Yeah, so thank you, Dr. Nelly. I think for the committee, we'll have to just line down here because the numbers are is a bit huge. So we can line up just in front of Dr. Nazila and Dr. Mulwa and Dr. Kature. At the Vice Karambi, you can also just stand next to Dr. Nazila. NSDCC Angela, please come stand next to Dr. Mulwa. My brother Kimosop next to Dr. Mulwa. Cordelia, please, you're also invited to come. I'm always tempted to ask Professor Nduati for many blessings. This team, you've raised number of doctors here. Prof. Kimayo, for the leadership that you've given us, please, you can also stand in. And any other representative from the DOS. Dr. Njeru, I'm also seeing you here, and Obare, you can come. Ken, you can come. We take this, might be our last photo for this year with you before you send me to missions. Thank you. So the CHEP community have been reminded that you also join us. Thank you so much. And it is my pleasure now to hand it over to Dr. Abut. Thank you so much. And I allow our MOH leads to resume their seats. So Dr. Grace, thank you so much. And once again, we appreciate you for giving us the time and appreciating the awardees. Asanteni sana.
Good afternoon, everyone. I have the singular pleasure of giving the vote of thanks. I have seen the many faces that have just come up as we are taking the pictures and the memories of our first meeting that we had in January to give our partners the vision of this summit just came alive. So I want to just quickly go through the different categories that we want to give a special thanks to. Without your support, we would not be here. There's a lot that has gone into this summit planning. There's been a lot of late nights, a lot of calls prior to coming to Mombasa, and even when we're in Mombasa. And I think you can attest that as government, as NASCOP, with the different partners, we have really tried to give you a wonderful and a meaningful summit. Makofi kwetu. So distinguished guests, development partners, our colleagues, ladies and gentlemen, as we come to the close of this successful Health Integration Summit, it's my honor and privilege to extend a heartfelt thank you to all who have made this summit a reality. First and foremost, would like to sincerely give our gratitude to our government representatives and the different ministries that are represented here, the directorates. I see you, Dr. Nazila, for the HPTU, the TB program, Dr. Kathure, thank you so much. The NCD program, Dr. Gadesha was here. NSDCC, Angela, with the different colleagues from NSDCC. The malaria program, I know Dr. Kiboro was here. the cancer program, Dr. Bor, and NHRL, Kerich was here, and the health financing. We really, really thank you for your support. The county leadership, represented by the different CHMT members, we have different CCs, the CDHs, the chief officers, the CASCOs, and all the CHMT representative. We really thank you. Additionally, we want to thank our different implementing and development partners, the UN family, Dr. Amenya, we are very grateful, and thank you for the unique voice that you bring to this space of integration. We thank our USG counterparts as well, and the different FBOs and academia that are represented here. Communities with all their diversities, thank you for the voice that you added as we are planning for this summit, and we appreciate you. The different technical experts, we really, really thank you. Your insights and engagements and commitment have enriched the discussions and strengthened our collective vision for integrated health service delivery. We also want to extend a special appreciation to our platinum sponsors. I want to believe that all of us have been able to share in a meal or two. And so our platinum sponsors, Roche, Unitaid, CHAC, Kenya Red Cross, NSCC, NASCOP, and Global Fund. Please, let's put our hand together for our platinum sponsors. Your unwavering support and strategic partnership continue to drive innovation and sustainability in health systems. Our gratitude also goes to our gold sponsor, Abbott Diagnostics. We appreciate you. Together with our silver sponsors, Ampath, United Pharma, CHAI, WHO, AHF, CHS, Hologic, Patek, Trinity Biotech. Please, let's put our hand together for our silver and our gold sponsors. We thank you for your continued collaboration and your commitment to strengthening health service delivery. We also want to appreciate our bronze sponsors, TICA, Cefaid, Orasure, Cooperative Bank, Mylan, and Questa, Abbott Molecular, for your support in making this summit a success. Please, let's give them a round of applause. For those of us who are able to go to the exhibition areas, you can see that our partners also came in large numbers to show us what they do in the HIV space, and we appreciate them as well. So ChemoQuick, HCFK, Africa Biosystems, TICO, Path Kenya, LVCT Health, we thank you for showcasing innovations, solutions that are critical to achieving integrated people-centered services. And to all the people who came to display their posters, we really, really thank you for making this summit very engaging. Please, let's give them a round of applause. I know that the organizing committee has been appreciated, but we would not be here without their leadership. And so I appreciate all the subcommittee leads. Dr. Nelly, you have really, really done a great job. This woman is a firehouse. I don't know where you get all the strength to do all the things that you do. She's still in school on top of everything that you do. But I also know that you had a very good team behind you. So, and I cannot even begin to name all of them, but please allow me to just give them a second to stand. All the members of the technical subcommittee, please stand up. We want to applaud you. You guys have done a wonderful job. They have given us an experience that is an international class. And you want to agree with me that it's been a good summit, isn't it? Yeah. So thank you, Dr. Nelly. We appreciate your support. I also want to appreciate the only Gen Z in this team, Rhoda Nisa. Rodanisa is our communication and advocacy lead. I know she's somewhere running, looking for photos and making sure that we look good somewhere. Oh, Rhoda, I see you. I see you. Thank you. Thank you for being a very cooperative Gen Z. And for all the people that were working behind you together with the MOH communication team, we appreciate you. We have the logistics team, the ones who came on the venue, made sure that we are going to be able to get this venue. Betty Chepkwony, please, let's appreciate that lady. She's done an excellent job at logistics. I also want to appreciate the IT team. I know Victor is not here, but the young man has not slept. Yeah, just making sure that we have nice looking tags and that when you come to the registration desk, you're able to be allowed in. There's a lady who's been working a lot, Rose Angwenyi. I know M&D is not a cup of tea for everyone, but you made it look palatable for all of us, and we appreciate you, Rose Angwenyi. And to the different members of the subcommittee, the partners, and all the support teams whose tireless efforts behind the scene ensured the seamless execution of this summit. I want to also thank my immediate boss, Dr. Newton O'Malley. Dr. Newton, I appreciate you. Dr. Newton has taught me a lot. If you see me looking nice, I am trying to compete with this three-piece. I know I cannot keep up to that, but thank you, Dr. Ray. I honor you and I appreciate your leadership. I also want to appreciate the father of this summit, Dr. Mulwa. Dr. Ray, your leadership has been exemplary. You have worked a lot around the clock. We have seen you making 1,000 calls to make sure that we are here. And I think all the success of this summit can be attributed to you. We honor you. We appreciate the tireless nights that you have put in for this summit, and may God richly bless you. Please, let's clap for Dr. Mulwa. And finally, we thank each one of you for your dedicated and support towards advancing integrated health services in Kenya and beyond. Dr. Cordelia from Uganda, thank you for coming and giving us a regional look. We thank you, and please pass our regards to your permanent secretary. We love her and we look forward to continue working closely with Uganda. So let's carry forward with the momentum. I think the work has just started. I like the diversity in this room. And when the work starts rolling, let's all fold our sleeves and get to work. This is just the beginning of the momentum. For us to achieve the commitments that we've committed to, we have to keep that momentum. And so a round of applause for all of us seated here for committing to see Kenya change the face of healthcare. It is not just a HIV agenda. This is a health agenda that will impact generations to come. So thank you very much for all of you who've been here. And I know I'm standing between you and lunch. This summit would not be complete if you didn't hear the voice of the father. And so Dr. Mulwa, kindly come on stage and officially send us home. Thank you very much.
Thank you very much, Dr. Abut. Let's applaud Dr. Abut once more. Sometimes I look more confident than I usually am inside, but I wear a very confident face. On Sunday, when I stood before you, I was a bit anxious because we did not know how the summit would go, how we would manage the sheer numbers of delegates that had shown up, and we were like, shall we pull through? First, I want to take this opportunity to thank all of you for coming. I think the last 5 days, we've had very, very insightful deliberations that have been thought-provoking in very many ways. We have had the status quo challenged. We have been pushed to think not just out of the box, but without one altogether. That if we are to succeed, we must do things differently, and that difference can only be measured if the clients, the patients that we serve can recognize. They don't know, by the way, that whether we are in Mombasa. But if next week but one, next year, that they will start seeing improvement of care, then this summit will be meaningful. And I believe the conversations that we have had were around that. The team that prepared, and you have been, everyone has been appreciated by Dr. Abut. I do not have words to thank you. I think I saw the teams meet during the mornings, evenings, night, and it was really overwhelming for some of you. Dr. Nelly, I don't know how you have been able to pull through. The team here may not have noticed. There have been a lot of changes in the program, panelists and stuff, but somehow we did not notice that there were changes, but she has been able to do that. I don't know how you've been able to manage that, but we appreciate all of you. I think mine is to wish you journey mercies as you go back. We have just begun the conversation. The real action is going back to our spaces and ensuring that integration actually works. For us, from the ministry, working with the counties and our implementing partners, we will provide the leadership and stewardship that is required to ensure that is actually realized. I want to wish you journey mercies as you travel back home. I want to wish our Muslim brothers and all of us, it's called Eid Makbul. Eid Mubarak. Yes, it's Eid Mubarak. I also want to ask you, like the governor said, leave all your money in Mombasa. That's what the governor said. So you have an afternoon. Let's also take time and enjoy Mombasa. There's a reason why we came to Mombasa. Some of us have not even been to the ocean. I think it's time to take time, walk by the beach, and relax a bit. When we go back to our places of work, let's start the integration journey. There's a feedback, there's a QR code that has been shared on the screens. Kindly take a minute and give us feedback on how the summit was. I think I have overwhelmed by your support. I feel the room is still full. 1.5 hours after our scheduled planned closure, and I feel there is a lot of enthusiasm in this subject, and we are going to make the change that we all desire to see. I now ask someone, I think we can have Muslim faith, someone to lead us in a word of prayer, and a Christian faith, someone to read. Dr. Ruzuna, I'm looking at you to pray on behalf of the Muslim faith, and Dr. Omesa on behalf of Christian faith. You seated next to each other. Then thank you, safe travels. Thank you, everyone. After that, DJ, the national anthem as we close the event. I now, with the powers bestowed upon me by the Ministry of Health and the Republic of Kenya, declare this summit officially closed.
Good afternoon. Yeah, my name is Ruzuna Moturi, representing Ministry of Health, NASCOP, and may we be upstanding to have a word of prayer ahead of our Eid that is scheduled for tomorrow. So let us pray. I will pray in Arabic. A'udhu billahi minash shaitani rajim. Bismillahir rahmanir rahim. Alhamdulillahi rabbil alamin. Ar-Rahmanir Rahim. Maliki yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. Siratal ladina an'amta alayhim. Khairil maghdubi alayhim. Waladhdallin. Amin. Thank you.
Good afternoon. Let us believe and pray. Our everlasting, kind, and loving Father who art in heaven, we humble ourselves before you. We thank you, Lord, for the gift of the day, for the gift of life. Thank you, Lord, for this moment in time. Thank you for assembling us here, your people, since the beginning of this summit on Saturday, where you bestowed your blessings upon us and we started successfully up to this point that we are coming to an end. You are faithful, Lord, because you have journeyed with each and every person who is here. You have bestowed the wisdom to this nation and its leaders to come this far to discuss the matters that touch on the welfare of Kenyans. We thank you for the leadership of the Ministry of Health, starting from the CS, the PS, the DG, and all the directors and leaders, the respective programs. We thank you for the program officers. We thank you for the stakeholders, including partners, communities, and every individual who's represented here, for granting us the opportunity and health to come together again to discuss matters that affect the health of our population. We pray that, Lord, that the deliberations that have taken place this week, that you may continue to order our steps to realize the commitments that we have made, to translate them to action, and to impact the people's health in this country. As we leave, we ask that your presence may be with us, may you walk with us from today and even the many days ahead, that we shall always also remember to come back to you to give you glory and honor. We pray this trusting that that which we've not prayed for, that your Spirit may intercede for us, for it is in Jesus' name I do pray and believe. Thank you. Amen.
Ilete baraka kwetu, haki iwe ngao na mlinzi, na tukae na udugu, amani na uhuru, raha tupate na ustawi. Sundangaliseba, ambimure bakusundangaliseba, abantu bo, ambimure nenga kusundangaliseba, abantu bo, ambimure nenga kusundangaliseba, siriya, siriri, siriya, siriri, siriri, siriya, siriri, siriya, siriri, siriya, siriri, siriya, siriri, siriri, siriya, siriri, siriya, siriri, siriri. Mwanamberi bayaye, mwanamberi bayaye go, mwanamberi mishekoro, mwana wamberi bayaye, mwana Vayanyego
Mwana wa mbere ni shekorero etibire tutwonokura
Mwana wa mbere
ubikumuha
Mwana wa mbere ni shekorero
etitulo tutomwakura
Mwana wa mbere
ubikumuha
Mwana wa mbere ni shekorero Omwana mbere ni shekorero Omwana mbere ni shekorero Omwana mbere ni shekorero Omwana mbere ni shekorero
elenya kutunyura
Sana kulipa